Good afternoon, everyone. Welcome to the first day of our conference. We will begin with our first session of the day titled Neurobiology of Trauma. And it's my privilege to introduce our speaker, Dr. Shalini Anand. Dr. Shalini Anand holds an MA in psychology and MPhil and PhD in clinical psychology. With over 33 years of experience, she specializes in counseling, psychotherapy, and trauma work. She is a trauma therapy practitioner, trainer, and supervisor, and she trains therapists in trauma informed psychotherapy and EMDR. Her expertise includes trauma therapy, couples and family therapy, sexuality education, and mental health awareness, along with extensive experience teaching and supervising postgraduate psychology students. Please join me in welcoming Dr. Shalini Anand to the stage. Please.
Good afternoon, everyone. Um, on behalf of the organizers, I want to apologize for the delay. Although I don't know anyone had any role to play in this, it just happened. So we hope to have a good 2 hours for this workshop, for this learning. And because it's a workshop, it's not just a lecture. I expect all of you to participate, and you're most welcome to participate. Okay. So we are talking about one small topic in the entire trauma informed psychotherapy, which is the neurobiology of trauma. Okay. So whenever we are talking about trauma, we have to first take care of ourselves. Charity begins from home. So we have to first take care of ourselves in the sense that although it's a very short workshop, but sometimes when we are giving examples, and because all of us are human beings and all of us have many things going on in our lives now or in the past, sometimes things can be a little triggering. So it's very important to take care of yourself. You saw me having water, so you also please have water whenever needed. I hope you've eaten something, and also avoid giving any examples at all from your personal life, and also don't give any detailed examples. When we go into the details of anything, it is usually more triggering because we are going into the details of the memory for ourselves or even our clients' examples. So, may I know a little bit about what has brought you here? What do you want from today's workshop? What are you looking for? Anything?
I'm undergoing training in one of the trauma therapies, ISP. So I thought this would be interesting for me to attend. So I myself use EMDR with my clients. So I wanted to know if there is something I can learn and take back from this workshop.
Yes, please.
Hi. So I think in genuinely today's world currently, I think trauma is something that every practitioner should be specializing in, if not possible, have some kind of understanding of it. And I see a lot of clients that come up with this kind of an area where they need this kind of assistance. So I think it's better to be knowledgeable about it and be able to help them. Hence this.
Thank you so much. So, most of you are looking forward to learning some. So, I am dealing with children who are undergone some kind of childhood trauma. So, I just want to know when and how to refer and what are the dynamics of it. Don't refer, you learn how to treat them. I mean, you can refer also. So, yes, these are some of the things which I want you to remember. And I don't mind if you want to get up and stretch anytime, try to avoid chit chatting. It's okay, sometimes something is very exciting, but avoid it if possible because otherwise it distracts the whole group. So, before we talk about the neurobiology of trauma, one question is what is trauma? Trauma is one word nowadays which is being overused and still very, very underused. So it has become a little bit of a fad. Like I think about 10 years ago, it was mindfulness. Maybe about 10 years ago, before that, it was more of, I don't know, CBT, maybe now DBT was there maybe 20 years ago, a lot. Everyone was talking about it. So this has become a fad. In every website, you will see people writing trauma informed. At least as a word, they are using it a lot. So, what is trauma? And if we ask anyone what is trauma, they may say a few things, even if they are not at all from the field of mental health. What do you think they might say? They might say trauma is something. What does it say? Then they might say what? Thank you for the nice music in between. Yeah, so we people may say trauma is something if we are getting reminders of that again and again, we are remembering something, that is trauma. Or people might say we are trying very hard to forget something. Okay, but what has happened. It can never be undone. Very commonly, people would say that. Or sometimes people say some experiences which were so painful that now we can't remember them. Opposite is also possible. That either we are remembering them all the time or it has become a blank, memory has gone blank. Okay? Someone, a layperson, might also say a few more things like life happens to all of us. Yeah, read out. So people say, what is the big deal? Everyone goes through so many things. Why are you using the word trauma? And then, someone from my generation may say, all these young people know everything they call trauma. Right? So then people might also say trauma refers to only extreme experiences which are severe physical abuse or severe sexual abuse. And this is very rare. Trauma doesn't happen to us, it happens to someone else. Or we might say, if something has happened 40 years ago and they are saying they are still disturbed by it, then they are very weak. There's a problem with them. It's a very weak person. Or they don't want to get over, they want to remember it. So it becomes their fault. Or sometimes people say stress is the same as trauma is same as stress. Sometimes people say they are interchangeable. Then if you ask lay people about what is trauma therapy, people would say in that you have to keep going and talking about what happened, and the therapist has to keep asking what happened, tell me more, right? Now people also say that psychotherapy, even if it is trauma informed therapy, it cannot really treat trauma. That's what lay people would say. It can only help analyze, oh, you feel angry about this because this has happened. Or they can make us feel heard. We feel lighter because we have just taken everything out. Or at the most, therapy can help us learn different ways to cope. Trauma will remain there, but we will only learn different ways to cope. Now, I have a question for all of you. Would you agree? If yes, why? If no, why? Quickly answer, please. Last point. All of them. All of them. No? Some extent, yes. Which one do you agree?
That one, that like some because the physical, that physical accident, something like happens because that affects mind also. That I agree, but not all.
So, which one do you agree with?
Like physical experience, like accident and all.
Physical abuse, sexual abuse?
No, it's not abuse, like injury.
So, you're saying people can never get over it?
No, ma'am, they can, but it depends on the person's individual person's like. So can psychotherapy help people get over it? Yes, ma'am. Definitely.
Sometimes psychotherapy will also require medication as well. So I believe that with psychotherapy, sometimes medication is required. So I would not agree with the fact that psychotherapy alone can treat trauma. Yeah, so sometimes anti-anxiety drugs or whatever has
Cannot be trauma.
yeah alone.
Okay. Speak loudly. The goal of therapeutic module, which is trauma informed, is not to help clients to get over the trauma, but to help clients that if certain experiences were controlling their behavior and their things in the present, they no longer have control over it. It's more like healing. Because what has happened. But if a client is still stuck and kind of being influenced by what has happened in the past, knowingly or unknowingly, psychotherapy.
Please settle down quickly.
A trauma-informed approach or a trauma-informed therapy helps them to work on that because
Okay.
trauma is not what happened in the moment. Trauma is what happened to us in the moment.
Does anyone think that if there was a memory that was disturbing us a lot, it is possible to not be disturbed by it even 0.1%? Is it possible? No? Okay. Some of you said yes. How? Okay. So I don't agree with any of these things. None of them. Psychotherapy, even without medicine, can completely treat trauma. Okay? And that is what all of us should learn. We have to empower and equip ourselves to learn that. A small request, can everyone please put your phones on silent? I know you may get important calls, but maybe on vibrator mode so that you know that you're getting a call, but others don't. Anyone wants me to explain why I disagree with any of them? Please feel free to ask. You agree? Huh.
People are exaggerating if they call everything trauma because everything cannot be trauma.
Okay.
That is the part which small part I agree.
Okay. You are right. So in the previous slide, we had said all stress is trauma. Okay. I have had to travel from another city to do this workshop for 2 hours. I cannot call it trauma unless, something major happened there. Unless something happened, maybe my flight was about to crash or something like that. Everything is not trauma, you are right. But something which was affecting us for 20, 30, 40 years, even 5 years is trauma. If it was either coming to our minds again and again, which is called flashbacks. If we were getting flashbacks again and again, or if it has changed our belief system. If it has changed our belief system, meaning CBT people, so the cognitive triad that we know of, suppose we have negative beliefs for ourselves, others, or future, that is the depressive triad. Or, you know what is the anxious triad in CBT? I am vulnerable, not unlovable. Unlovable is depressed. I am vulnerable. Future is unpredictable, uncertain. In depression, it is future is bleak. In anxiety, future is unpredictable. What can happen? What can happen? And other people are dangerous or threatening. That is the anxious cognitive triad. Now, when you read CBT books, they say that core beliefs come from genes, past experiences. If a past experience can make our belief like this, that experience is trauma. Okay? Okay? Irrespective of everything else, I remember it too much, I've forgotten it, I want to forget, I want to remember. You leave all of that. If it has changed my belief system, it is trauma. Okay? So, psychotherapy, the usual psychotherapy, the talk therapy, is very helpful. I have done psychotherapy for a good 22 years or so, after which I got into trauma informed therapy. So it helps, but it helps us to feel better. Trauma informed therapy helps us to get better. There is a difference. We only feel better, or do we actually get better? So when we have all these views, which even lay people have, everyone has a view about psychology. Everyone. People may or may not say I know cooking, but everyone knows about human mind. Okay? So I have someone who was doing catering work for us. He asked me, what do you do? I said, I'm a psychologist. Madam, I am also a very good counselor. I said, very good. I am not a very good caterer, but you are a good counselor. So, how does the neurobiological perspective add to what every layperson knows about human mind? So, if we look at it from, if we define trauma from a neurobiological perspective, we say trauma is anything that is too much. Now, too much means what? Your too much may be different from my too much. Something is too much for you, not too much for me. Something else is too much for me, not for you. So, whatever is too much for that person. Or if it is too soon, I was not prepared for it and suddenly something happened. Or too fast. Too soon is more related to age, at what age something happened, and too fast is too quick, without any preparation, without any reminder, without any warning. Okay? So now what happens is that if our nervous system is not able to handle it, our nervous system is finding it too much, too soon, or too fast. I am not thinking that it is too much, too fast, or too soon. My nervous system is finding it too much, too fast, too soon. Then it becomes trauma for me. So someone else cannot define what is trauma for me. I cannot define what is trauma for you. Okay, so our nervous system decides. And especially if there's no repair work, if the nervous system cannot even find now what to do, how to cope with it. So, this is how we define what is trauma according to our neurobiology. Okay. So, I'll give you one or two examples. Suppose I had a client who said that I was 4 years old and I was always very curious about the lift. And we used to live on a 10-story building. And my father once entered the lift, took me in, and he pressed the button for the 10th floor and he got out. And the lift closed, and I was alone in the lift for 10 floors. And he was a 40-year-old man. And he's saying, I can just not forget that. And after that, I never get into a lift. So, is that trauma for him? But it may not be trauma for someone else. Someone else might find it a game. Right? So, but for this person, it has become trauma. So, like that, there are many examples that something has become trauma for someone but may not be for someone else. Okay? Now, the first few which I told you, are called overwhelming experiences, which very roughly equate with abuse experiences. Okay? Something is too much, too fast, too soon. But we don't talk enough about underwhelming experiences. The word overwhelm is very commonly used nowadays. Oh, I'm feeling very overwhelmed. Nobody says I'm feeling underwhelmed. But especially for a child, when the child is not receiving enough stimulation for the nervous system. Maybe they're not getting enough eye contact. Maybe they're not getting enough hugs. Maybe they're not getting enough positive words or the tone or the presence. Someone is around me physically and emotionally attuned to me. So they're not receiving enough of what is the basic requirement for them to feel safe internally. That becomes underwhelming. So that is usually neglect experiences. Okay. So some of you must have heard of ACEs. Do you know what is ACEs? Yeah. Adverse childhood experiences. So adverse childhood experiences, at least 10 experiences. So while I said that something may be trauma for me, not for you, and vice versa, but usually ACEs we assume would be traumatic for everyone, with maybe with rare exceptions. So in ACEs, adverse childhood experiences, we look at three kinds of abuse: physical abuse, sexual abuse, and emotional abuse. We also look at two kinds of possible neglect: physical neglect and emotional neglect. Sometimes we also add medical neglect. So if you look at the longer version, there are 16 ACEs. In the shorter version, there are 10 ACEs. But at least 10 you can say universally. Okay. So now if someone says, oh, this happened long ago, that is a very invalidating thing to say. Okay. Now, so the two types of neglect refer to the lower part, that is, something is too little. Okay, that is neglect. Now, this is something which lay people may or may not agree with, that there are changes seen in brain scans, PET scans or CT scans, which you are familiar with. PET is positron emission tomography and CT is computerized tomography of the brain. So you can see the differences in the different sizes of the lobes. So this is a healthy brain which has less space, and here you can see especially temporal lobe is so much lesser. Similarly, neglect. Many times people say, oh, nobody has beaten you, nobody has done anything to you, why are you saying you did not feel loved? So even neglect, the brain shows, this is the normal child's brain. This is a study by Bruce Sperry, who is an authority in neurosciences. This is a healthy 3-year-old child's brain. This is a neglected 3-year-old child's brain. You can see the size of the brain is so much shrunken. Okay, so the feeling abused and the feeling neglected are not happening because we want to not forget them. It is actually, there is evidence in the brain. Now, when we look at the neurobiology and trauma, what is the link? The word neurobiology just means the biology of our nervous system. Some little bit we study about the nervous system in our undergrad, postgrad, all of us. So, whenever our biology does not have the ability to cope with anything, it becomes trauma for us, like we saw. All types of traumatic experiences, whether or not we accept them as traumatic, can leave a very long lasting impact. Now, long lasting impact, as we saw a little bit, can be in the form of belief systems. In what other ways do we see the impact? Relationships. Very, very often people would say, if they, all of you must be having clients, I can only give you my client examples. I have clients whose parents either divorced, which is bad, or they did not divorce and kept fighting, which is worse than divorcing. So they come saying, I will never marry, or I will never find a partner. So they may not say, I have trauma because of what parents did, but the effect in their minds is so deep that all marriages are horrible, or all men are horrible, or all women are horrible, something like that. Some belief system has been changed. So we see the impact in the form of belief systems, in the form of relationships. Okay, relationships, not just romantic relationships, even amongst friends, even amongst colleagues. So, amongst colleagues, you will always have some people who would say, I get bullied in the office. Okay, everyone dumps all their work on me. Okay, why do you think that happens? Anyone who says this, anyone, what you will find is, whether they tell you or not, in their childhood, early childhood, they were a very, very good child, very nice girl, very nice boy. Okay, to the extent that they were parentified. You know the word parentified? All of them. Okay, I can see some of you smiling, so you know the pattern. That anyone who is now becoming a victim of bullying has been a parentified child. Why is that so? 20 years ago, 30 years ago, they were a parentified child and now they are getting bullied at work. Why does that happen? So, okay, the answer, sorry, I didn't give the mic. The answer is that it comes from lack of assertiveness and people pleasing nature. All the people pleasing, anyone in the world you see has people pleasing, whether they tell you or not. It has always started from parent pleasing. Whoever is a people pleaser today was a parent pleaser in the childhood. Yes or no? So now what has happened is, I'm not covering attachment theory today, but there is a neurobiology of attachment. So it's almost like the nervous system has stored in its memory that the only way to survive is to become a doormat. Okay? So that is what happens. Now, do we call that trauma? Parentification is a trauma or not? Now, all the soaps which will show that very nice child who's trying to find a partner for mummy or daddy, or who's trying to, that movie, whatever that movie was, Kaj, huh? So, or even in TV soaps where, always eager to make tea for everyone, eager to do this and that. They are all parent pleasers. They will all become people pleasers. They will all get dumped all the work in the office. So, is that trauma or not? So, this is how we need to learn how to define trauma. If you understand that there is a nervous system component happening, things are getting stored in the nervous system, and that is why it will be reflected. So, also, whatever is stored in the nervous system in our neurobiology, okay, sometimes people would say that, most of the times I like myself, but sometimes I feel so depressed and I think there is no one as horrible as me, no one as whatever unfortunate as me or as unlovable as me. Then, which is the belief they have? I am good or I am unlovable. But most of the times they're not thinking that. Then, so if I say I'm good, if that means I'm not good, then only that condition will make me good. Otherwise, I'm not good, isn't it? So that's why how we understand, moving up from layperson understanding of trauma, we have to learn to define trauma in neurobiological terms. So all the emotional trauma or psychological trauma is much more neurobiological than it is psychological. Okay. Now we will do a little bit of exercise. Okay. So if you hold your palm up facing me, put your thumb inside and fold your fingers over the thumb. Okay, and you can do it with both the hands also if you want. So this is roughly our brain. This is the right hemisphere, and the left hand, if you do, that is the left hemisphere. We have two hemispheres, right and left. Now, in this, we have, so our brain is very complex. Everyone knows that we have many, you can put your hands down, but keep the fist if you want. So, we have several billion neurons and several trillion to even a 1 or 2 quadrillion interconnections between neurons, right? Every neuron connects with several other neurons. So, to make it very simple, there was a theory given by Paul MacLean, which is called triune brain theory. Some of you must have studied it, which says that brain has broadly 3 parts. So the fingers, all these fingers folding here, is the higher brain. If we could lift the higher brain like this, the thumb and the area around it is the middle brain, and this heel of the palm is the lower brain, then connecting to the spine. So higher brain is also called the human brain, middle also is called the mammal brain, lower brain is also called the reptilian brain or the lizard brain. Okay, so higher brain, middle brain, lower brain, human brain, mammal brain, reptilian brain, thinking brain or analytical brain, feeling or emotional brain, sensing brain, sensations, 5 sensations, 5 senses. Okay, so now Paul MacLean's theory of triune brain has been converted into this hand model of the brain by one psychiatrist who is a very prominent psychiatrist in the US called Daniel Siegel or Dan Siegel. Okay, so the higher brain does everything that we humans are very proud of, like thinking, planning, coordination, foreseeing the consequences in the future, whatever we are doing today, what will happen after 2 years, after 5 years. So that is the ability that the higher brain has. Okay. Now the middle brain is like the adolescent brain who has a lot of emotions. Okay. What are our emotions? Happy, sad, angry, scared, shame. So all the cravings that happen right now, if some of you are wanting to have coffee, that is happening, something is happening in the limbic brain. If you're thinking of your ex and you want to call him up, especially after you are a little drunk, that is happening here. Okay, limbic brain. And the lower brain is something which we are almost completely born with. So this is almost completely developed when we are born. So think of whatever a newborn baby can do. Everything is happening here mostly. All the 5 senses, touch, taste, smell, see, hear, all 5 senses, digestion, blood circulation, heart beating, reflexes, all the reflexes, and yeah, so digestion I said already. So all that is mostly controlled by this, and this is also closest to the spine. So reflexes happen mostly in the spine, we know that, right? Now, as the child is growing slowly after 8 or 10 years to about 15, 16, 18 years of age, the limbic brain is completing its development. Okay. So, this higher brain, while it also does thinking and planning, some of you are quite trained in all this. So, prefrontal cortex is trained in all this executive functions, but we also have orbitofrontal cortex, which is like down here, which is also important for impulse control. Impulse control. So, our emotions are happening in the limbic brain, but the higher brain goes under the limbic brain also and controls the emotions. So, very often I give the example, usually we have a ceiling fan on the ceiling, but the regulator is on the wall. So the emotional regulation is happening in the higher brain. Now this higher brain develops the last phylogenetically and ontogenetically, which means that even in evolution, humans are the last so far. We don't know after that what will happen. So only in humans it is the most developed, and even for one particular individual, it develops the last. So it's developing till 21 or even about till 25 years of age. So which means emotional regulation and many of these other functions become completely accessible to us only till that, after that age. Why are we talking about this? Why we are talking about this is when whatever is developing, then anything that is happening will affect that developing part the most. Okay, so in early childhood or in childhood till adolescence, these parts are developing the most, the lower parts and the middle brain. So that's why these parts are affected the most. But the higher brain is in queue. Please wait, you are in queue. So it's also in queue. So sometimes this development also gets delayed or compromised because of trauma. Now, so when we are doing trauma-informed therapy is very different from trauma-uninformed therapy. In trauma-informed therapy, we cannot rely only on the higher brain. What do we mean by that? Not rely only on the higher brain. Thinking, cognition, language. So language is where limbic brain doesn't have language. You can speak whichever language, doesn't matter. The tone matters there. Lower brain also doesn't know Chinese, Japanese, nothing. It knows how, like, boom, like that. If you talk, it will get started. Okay, it doesn't know which language. Now, most of the therapy that we are trained in is relying on talking. If the injury is here and we are healing this part, it's like if I fall down, I fracture my right arm, the doctor puts a bandage on the left arm, what will happen to my right arm? It won't heal, right? So that is what happens most of the times because we are not trained in trauma-informed therapy. We are healing the part which does not require the most healing. Which is why it's important to understand the neurobiology. Where is the healing needed? And that is the part which I need to heal. And I need to learn methods which can heal that part. So, have you heard of top-down approaches and bottom-up approaches? Does anyone know what is that? Any guesses? No?
And it's kind of reality from top to it will go down, down, and from bottom, like from bottom to up. Like reality works.
Which top and which bottom?
The top.
Huh? Sorry?
Self-regulatory levels the top. And then memory, attention, and then moving on to the sensory experience. That is from top to bottom.
For example, which therapy do we know like that? No. So that's, I mean, indirectly, yes, it's correct. But tell me the names of therapies that you know. CBT and more CBT, and what else do we know? DBT, which is also CBT. Then IFS, okay. EMDR, okay. Somatic experiencing. Then EFT, which EFT? Emotion focused, okay. Psychoanalysis, no one knows psychoanalysis.
Analysis.
Okay.
Nobody practices it.
Nobody practices. No, no. Many people practice. Then we also know mindfulness. Everyone knows mindfulness. Now, top down and bottom up means that we are starting therapy here. So, if we start the therapy from talking, discussing, analyzing, understanding, all these therapies which you said are doing that. So, they are all top down, top, and they hope that the effect will go down. Hope. We don't know. Does it go down? Maybe it does, maybe it doesn't, but that's the hope. So, top down. What do bottom up therapies do? Bottom up therapies, we do not talk. So, we start from the bottom. Sensations, emotions. We don't discuss, we don't discuss, we don't analyze, we don't understand. But the hope is that the effect comes also here because belief systems are here. If trauma happened here and the effect has come till here, now if we do therapy here, the effect will also come here. Yes or no? Okay. All of you will remember the hand model of the brain. Some of you must be already knowing also. But should we do one small exercise? Yes? Okay. If possible, put your stuff away. I mean, it's okay. You don't have to, but if you put it away, it'll be easier. Okay? I want you to think of anything which you have been wanting to do, but you have not been able to do. You have been wanting to do this, but you have found it very difficult to do, and sometimes it feels like you will never be able to do. You've tried it, you've planned, you've done whatever, or sometimes you are too scared to even try it. Okay, so swimming, maybe losing weight, maybe most of you are younger. After you reach my age, that becomes one goal of life. But yeah, I mean, whatever, one thing that you have been wanting to do and you have found it difficult to do. Now think, how difficult is it? 0 to 10. 10 means it feels impossible. 0 means it feels very possible. Just give one number. Think of only one thing and think of only one number. Okay? Everyone has this? You have it? Okay. All right. Now, part 2 of this exercise. I want you to think of another thing, any one other thing, which you really thought you will never be able to do. And then you were able to do it. Everyone will have at least one example of this. You thought you can never ever do this, but finally you were able to do it. Everyone has at least one example of this, right? Now I want you to visualize in your mind, visualize how you were able to do and how you felt after you were able to achieve it. So spend 1 minute just visualizing how you were able to do it. You can visualize with your eyes open or closed. and visualize the feeling you felt after you were able to achieve it. If possible, you can uncross your arms. It becomes easier to notice it. Try to remember how wonderful you felt after you were able to achieve it. Wow, I can do it. Can you notice this sense of achievement in your body? Scan your body from the head to the toes. Just notice where in your body you feel a little open, a little expanded, a little free flowing, calm and rested. Everyone has this? Okay. Now, with your eyes open, you can look at one spot wherever you look. Looking at which spot makes you feel the most open and most expanded in the body and most able to remember the experience of, aha, I have been able to achieve it. Don't try too hard to find the spot, just allow your eyes to go where they go. And enjoy remembering, wow, how I was able to achieve it. I can do it. And also try to find a number 0 to infinity. How much of that great feeling you're feeling when you're remembering this? 0 to infinity. Okay. Now keep looking at that same spot which you have. And now try to think of the first thing that we thought of. That one thing which you thought you can never do. Okay. Take your time and come back here whenever you want. Does anyone have anything to share? It was a very mild exercise with it. Anybody has anything to share? Yeah.
I felt powerful that everything he said.
I felt powerful and I felt that whatever I want to achieve, I'm capable of achieving.
And when you thought of afterwards, when you thought of that one thing which you could not achieve, did you feel more capable of doing that?
After that is the thought. I'm capable. Anybody else?
I think it spilled over the thought that I can do this. I found myself repeating that for the thing I thought I couldn't do also. I can do this, I can do this, and the feeling of warmth and
So how possible did it feel to be able to do that thing?
very much it didn't feel like a big deal.
Anybody else? Anything to share? You can also share if you did not find it helpful.
Okay, hello, ma'am. So, I'm a teacher, I'm a faculty, and being a teacher is something that I never thought that I would do. But then fate brought me to a place where I had to start teaching. And when you asked us to look at something that, our eyes take us, my eyes went to the clock. Somehow, because I think I took it one day at a time, and my student is sitting right here, and the things that I hear from my students, it makes me feel like, okay, even though I thought that I could never do it, I am in fact doing it every day. And the thing that I think that I cannot do, maybe it's something that if I work on equally hard that I did here, it would be achievable as well.
Okay, great. Thank you. Yes, you were saying? So, the trauma, the incidents, what we say, ki, what was not achievable, what something which you could not feel like achieving, and what you actually achieved. If the what you say, the intensity is different. Like what I fear of not achieving is way too intense, and what I am thinking is achievable is something which I, with practice, I would have. Won't that affect the way we are thinking whether we can achieve or not the fearful situation? Good question. So, of course, it can affect, but the question was, second part was what you thought you can never ever achieve, and then you were able to achieve. So, I mean, we didn't do, because it's a large group, we can't do the intensity of the first and intensity of the second, but the second is also supposed to be that which I thought I can never achieve, and then I was able to achieve. But of course, it can be different. Yes.
So there was a shift in my nervous system, which I noticed. So initially, the first part of the exercise was making me feel heavy, but when I revisited it again, it made me feel lighter. Yes.
Yeah.
So mom, the activity that we just did right now, I want to note present 2 points as a part of this. Number one, definitely in the first half, when we were talking about things that we couldn't achieve, we wanted to, but we couldn't. Definitely, it left a sad feeling. But at the same time, I also noticed how my body reacted to it. I could feel a little uh, I could feel a little tightness in my chest, feeling of nervousness, but at the same time, I could feel my muscles in my shoulders clenching up. But then later on, when we talked about the things that we never thought we could achieve, but we were able to achieve, that suddenly created a shift in my nervous system, and I could feel a lightness in my chest, my shoulders dropping down. And in terms of the feeling, definitely it made me feel really good about myself, reminding myself that what I am capable of. And when rethinking about the thing that I was not able to achieve all together combined, I can clearly sense a great shift in me in how I was able to perceive the things that I was not able to achieve previously and after the exercise. There was a great shift, and now I actually feel that if I try again, I might be able to achieve it.
You will be able to. Thank you for sharing. So, thank you for sharing all the positive experiences. I'm wondering, was it helpful for all? Wasn't there anyone who thought, what is everyone doing? It's not helping me at all. I am not finding any change. Yes, go ahead.
Yeah, and it's not like that, but I know my experience in general. So again, even with first thing, it was easy to imagine, oh, what is something that I cannot do, and even with the second question of, okay, what am I? I had to think there was a delay. I'm like, okay, what did I even do? Like sort of, but again, I found something. I felt good, but I could actually feel that there was a block here. Like there was actually a block here. But somehow I was trying to, okay, it felt good, felt good. It's almost like I had to. But then when you asked, okay, now what do I think about the first thing? I couldn't remember. First of all, I forgot. And I tried remembering, and I'm like, oh God, this is something. So this was very distracting, the whole thing. Not because of what's happening externally, I'm sure. So this was my experience. There was some numbing to the whole numbness.
It's okay. Thank you for sharing. That's what I was wondering. It can't be like in a large group. Yes. Can you please give the mic to him? There.
Hello, ma'am. Ma'am, so when you asked about the first question, there were two things that came to my mind. One was a behavior that I was not able to do, and second is something I am not able to believe about myself, or, for example, I can't love myself. That was the thought. So when I later did the activity again, for the first part of it, I felt more confident that it was related to maybe exercising. So I thought that, okay, I'll be able to do. But the second part, I still did not feel I'll be able to do. So, any reasons why that distinction?
So I never said down, now you have to believe that you can do. I never said that, right? Was there any shift at all?
Yeah, for the behavior, like for the exercise, I did feel that difference. But for the other one, I did not.
So the question was take one thing. You don't have to take two. It becomes too much, no? We are doing one thing at a time. So, I mean, there can be other factors. This is one factor. It's a very small exercise in a large group. Taking one thing becomes possible. Taking two things is a bit much. But I'm glad you could feel the change in one thing. What is the point of doing this exercise? Does anyone want to guess why did we do this exercise? What are we trying to do with that? Huh? I never asked you to alter the way you're thinking. What it feels when we think about? Okay. Good. What else? Anyone else? What are your thoughts about why we did this exercise?
Shift in emotions in the sensations when we think we shift in sensations in the body when we think it is something we can achieve and we cannot achieve.
So, till now we are used to saying, why do you think you cannot do this? You have been able to do other things and think about. So, we try to kind of convince the other person. Isn't it? That's how somehow, somewhere CBT, evidence for, evidence against, all of that we would do. Many times we would hear people saying, I know, but. So I know is happening in the fingers, the but is happening here. So also people say, even this example of contacting X, very common. I know, I have decided I will never contact my ex, but I was a little drunk, or I was very sad, and I sent messages at 2 a.m. and I'm feeling very stupid now. Okay. So the conflict between different parts of the brain you can see. So the decisions and the understanding and the clarity and the analysis and the discussion are all happening in the higher brain. When we are doing visualization, you did visualization just now. Visualization is not happening only in the higher brain. It's happening in the deeper parts of it happens in the occipital lobe also, because you're visualizing. It's also something about it, because I added one cognition. I was able to do it. That's your conscious memory, episodic memory. So that's happening in the higher brain and to some extent in hippocampus, in the limbic brain also. So we have incorporated several parts of the brain in doing this exercise, whereas if we do talk therapy, we are engaging only the fingers, only the higher brain. And very often people will give you all the correct, not people, when we go for therapy also, it's not other people are stupid, or we also, most of us go for therapy or should go for therapy. When we go also, we'll say all the right things. I know this is the thing, this is evidence for, evidence against, I should do this, I should not. Next day again. So the thing is, the changes have happened in the higher brain, but who has the fracture and who's getting the plaster is the conflict. So what I was just showing you a little bit of demo was that there are ways to engage other parts of the brain also. You did not talk anything. We did not do talk therapy. So the purpose of this demo was this, that there are ways to engage other parts of the brain. This I have almost covered already. So there are different parts of the brain which are affected due to trauma. So the beliefs, we spoke a little bit about beliefs. So we have a part called precuneus, which is in the medial frontal cortex, which affects our beliefs. I am, whatever, lovable, unlovable, worthy, unworthy, everything is happening in the medial frontal cortex. Then the orbitofrontal, which is, I told you, the regulator of emotions, and the ability to differentiate relevant from irrelevant. Relevant from irrelevant. Right now, in different situations, you go shopping, you went to buy bread, but you got chocolates, you got everything else because they arrange the counters like this to lure people. So if we are able to focus on the relevant and leave out the irrelevant, our higher brain is very good, very responsible for that. But those parts of the brain can also get affected because of trauma, and people may, even in discussions, people would talk about a lot of, they lose focus and go into irrelevant things. That is happening here. Then amygdala, everyone knows about amygdala, is the fire alarm center. So what happens with especially complex trauma, which is prolonged trauma, especially in the interpersonal circumstances within the family. Because of prolonged trauma, amygdala becomes big and fat, and hippocampus, which is near that, which stores the long-term memories, becomes a little shrunk. Hypothalamus becomes disturbed. So hypothalamus, HPA axis, hypothalamic pituitary adrenal axis, is responsible for all our endocrine system. So when everything is happening in the endocrine system, so neurochemical changes happen because of this trauma. So many parts are affected, but most affected are amygdala, hippocampus, and prefrontal cortex. So, which I have already told you. So, in prefrontal cortex, we know that higher thinking happens. Hippocampus is like the librarian, so who has the entire catalog sort of a thing, and also has the ability to form long-term memory. Amygdala and hippocampus are very close to each other. So hippocampus gets in, like they are friendly neighborhood, they borrow from each other. So hippocampus gets information from amygdala about how threatening something seems to be, and so it should be stored in the long-term memory for future reference. Oh, if this happens again, I can remember it so that I don't get harmed by it again. Okay. So we use the word triggering. We use the word triggering. What is the meaning of triggering? Everyone knows what is triggering? What is triggering? So if we hear of something, I have a client who came to me after this movie Thappad was released. Okay, somebody had bullied him in college and had slapped him. And just the name of the movie triggered him and he came for therapy. Ma'am, I just can't tolerate this name also. I have not watched and this and that. Then we did processing and then I gave him one homework. But after a lot of sessions, not in the CBT terms that, okay, go watch and like that. But we processed it first and then he was able to watch the movie and that memory was like a 9 on a scale of 0 to 10, and it became a 0. 0. Not okay, I don't want to be affected by it. It was a 0 afterwards. So, now what happens is that suppose this, if I take the same client example, in the moment of trauma, obviously, someone has slapped you and something like outside the principal's office or something like that. Now, when he hears the word slap or thappar, the body reacts the same way for him. The body again goes into fight or flight. So triggering is that whatever is reminding us of that, it takes us into that same experience. The neurobiology kind of goes into that. So the body is reacting, the mind is reacting in the same way as if it's happening right now. Okay. So the higher brain shuts down, the prefrontal cortex shuts down, and the limbic brain takes over. Now, limbic brain has amygdala. So amygdala will start firing as if it's happening right now. Okay. Now the loss of executive functions. Executive functions is our boss. This is the boss leader of the brain. So loss of executive functions means the boss is on leave and now there's a crisis happening. Now who will do what? Everyone will just run helter-skelter, try to do something which they don't know how to do. Now, the reason why prefrontal cortex is shut down, so we know that brain does everything. Our brain does everything only to help us. So why would higher brain shut down in times of crisis? Because while the prefrontal cortex or the higher brain, entire higher brain is the boss or the parent, but it's very slow. Now, in times of crisis, what do we need? Quick action, quick. Someone says, okay, let me think what will be helpful. Okay, you said we are all going to run. So it's like that. So the lower parts of the brain are very fast. The structure of the higher brain is, it's granular. We call it granular. So there are 6 layers of grains in the higher brain, because of which it's about 10 times slower than the deeper parts of the brain. 10 times slower is very, very slow. So then that's the reason. So when we say brain does everything to help us, this is the reason the brain shuts down the higher brain, that it's very slow and it is seeming like a crisis. We need quick action. So the parts which are not quick are asked to go. You take rest, we'll take the action. So even in times of crisis, it happens. And that's why the same thing. So this is why it's called triggering. So the brain is triggered almost as if it's happening right now. Okay. So then when we studied the 3 parts of the brain, higher brain, middle brain, lower brain. So there is a hierarchy in that. So first, the human brain under normal healthy circumstances. So assuming nobody is triggered right now and assuming nobody is too sleepy or too hungry and overall everything is okay, our human brain is engaged. Okay, hearing the words I'm saying, understanding, combining it with what you already know. So, kind of integrating your learnings. Suppose some cry, suppose some loud noise happens or some spark happens in something here. Then the limbic brain will take over first, which will do what? Fight or flight. Fight or flight. What is fight or flight? Fight or flight is, there is a danger. It's not thought, it is sensed that there is danger. Either I have to run away from here or I have to kill the danger. Depends. So the first instinct for a few moments, very few short seconds is flight, run away first. So our body goes like that. So that is flight, going away. Or we can kill the danger, like, some switch has to be turned off or a snake has to be killed or something, whatever. So either we run away from it or we kill the danger. Basically, the danger has to be finished. Okay. Suppose we cannot do that. So if human brain is not able to do, then the limbic brain takes over. If limbic brain also I can't do fight or flight. Neither I can kill this danger, nor I can go away, which is what happens in childhood abuse, complex trauma. Why complex trauma is the most difficult is because a child has no other place to go to and cannot kill the parents or whoever is, someone is much bigger, stronger, powerful. So can't kill them or can't go away from them. Then the lower brain takes over, which is shut down, freeze, collapse, which does not mean the child will collapse, which means the child can become a people pleaser, which means the child will learn I have no choice. I have to just go on. And as I said, we are not covering attachment theory today. Sorry, I have gone very far ahead in the slides, but yeah. So, the shutdown doesn't have to mean a fainting. Sometimes children start fainting also, right? Dissociative spells can happen. Dissociative disorders can develop. DID can develop. Anything can happen, but they're all happening in the lower brain, lowest brain. So there's a hierarchy: 1, 2, and 3. Yeah. So this is why we have to do also within a session. You can see that sometimes that blank stare. Where is the person in that? 1, 2, or 3? 3. Yes, very good. Or saying this happened, that happened. No. Then second, limbic brain, all the amygdala is seeing it as a huge threat. So when we are neurobiologically informed, then we will first recognize where the person is. And our intervention is tailored according to where the person is. If they are here, we can do as much CBT as we want, and it will be effective. Not if the person is here or here. So CBT is not wrong, but only CBT is limited. Okay. Now, this is a little bit about our endocrine system. So we have our adrenal gland, which produces these different hormones, catecholamines, cortisol, opioids, and oxytocin. They are all very helpful, but when they are too much and they forget to switch off, then they are all very harmful. So cortisol is also very good. Cortisol is getting a bad name as if it's a villain. No, cortisol is good, but it should turn off. With complex trauma, chronic trauma, it goes on, and so it doesn't get an opportunity to turn off. How much time do we have? We should start closing. 2:27. We have half an hour. People are not hungry, no? Okay. So, for example, let's say oxytocin. Oxytocin is known as the love hormone, right? When you feel someone and you start bells start ringing in your mind, that is oxytocin. Okay. Oxytocin is good. How can a love hormone be bad? It can be bad. How? Yeah. You know Stockholm syndrome? So in Stockholm syndrome, there is too much oxytocin happening, which should not happen. Can I please also have some water? Thank you. Okay, so starting to fall in love with our abuser. No, he's not that bad also. Hitler was a very nice person. No, really. He used to done a lot of animal welfare work. You should see his paintings. Wonderful artist. You know the childhood history of Hitler? Does anyone know? What is his childhood history? Huge abuse. His father would bash him every single day, and 2 or 3 times he was almost fatally beaten and was hospitalized. And his father was a Jew. So we understand his hatred for Jews. Imagine if he had received therapy. Yeah, Auschwitz would have not happened. Okay, so all hormones are good, but oxytocin is too much in people pleasing, in Stockholm syndrome. No, I had. She wants it. So cortisol, as I was saying, is good, but cortisol can make us feel very drained because cortisol is supposed to be get into action and finish, fight and flight, and it should be switched off. And then you should get some rest. But you don't get rest, it remains on. Okay, who will come today? Who will beat me up? Who will abuse me today? What will happen today? Who will shout? Who will do whatever? Then cortisol is not getting an opportunity. Do you know, have you heard of Gabor Mate's name? Gabor Mate. He says that there is no chronic illness in the world but for trauma. So, when our cortisol remains on, all the lifestyle disorders, cardiovascular, autoimmune, all the chronic pains, everything, all the IBS, all the chronic ulcers. So anyone who has fibromyalgia, anyone who has all of this, please go for trauma therapy first. Don't come only to me. My calendar is quite full, but there are a few other people. Now memory. Now this is another thing. When we are doing therapy with someone, we ask them directly or indirectly, what do they remember? We ask them, no? Now, I'll ask all of you. All of us know how to eat food. Do you remember first time when you ate food? No. So that means you have never eaten food. If you don't remember, then you don't know how to eat food. Do you remember first time you learned to walk? First time you learned to talk? First time you learned to write? We don't remember any of this. But we remember how to write and eat and talk and everything, right? So we have two types of memory, explicit memory and implicit. Explicit memory is also called conscious memory, implicit is also called unconscious memory. Asking someone what they remember is a very limited way of assessing memory because we are accessing only explicit memory in that. Implicit memory, we cannot ask, oh, this one used to beat you up, but do you keep remembering about it? No, I don't even remember. That means it's not affected them. That is the assumption we all take, right? Most of the times, if you're not thinking about it, if you're not remembering, then it has not affected you. So I always say, so you don't remember to write, so that means you don't know how to write, or any of these things. So implicit memory holds all the Pavlov's experiments are implicit memory. Do we have any procedural memory? Pavlov kind of memory? We know footsteps of people we like, we know footsteps of people we don't like. It elicits different feelings. We know when we go to this place, this person will have, some twinkle in their eye when they see us. So just to think of that twinkle in their eye, we feel happy. We know someone will be grumpy when we see them, then we feel very differently, right? So all that is implicit memory, because sometimes we won't even remember why we are feeling like this, why we are thinking like this, but we are thinking and feeling like this. So all that is stored in our implicit memory or unconscious memory. Very broadly, we divide explicit memory into two and implicit into two. Explicit memory can be semantic memory or episodic memory. Semantic memory is all the definitions. What is psychology? What is learning? What is memory? Who? How many prime ministers has the country had? All the information is semantic memory. Episodic memory is autobiographical memory. When I went to my first school, this was my teacher. I used to wear a pink frock. I used to do this, whatever, everything. Autobiographical memory is episodic. Implicit memory is also broadly divided into two: procedural and emotional memory. Procedural memory is everything that we automatically do, not just cycling. Cycling is only one example. Our talk, our facial expressions, this anything, whatever we are used to doing, slouching. I'm not saying any anyone, slouching or walking like that. Anything, any of these are all procedural memory. They are in our body. We are not even thinking about them. We just do it like that. Okay. Emotional memory is the memory of emotions. I don't know what happened, but I felt this. So the memory of the emotion is emotional memory, which can be sometimes not just the event, it can be sometimes a perfume. It can be a particular song, it can be a particular color, it can be a particular place, anything, a particular weather. Okay. So sometimes we work backwards in trauma informed therapy rather than only asking what happened there, what do you remember. We can start from what is triggering today. We process that, and the person may or may not be able to access the events, and it doesn't matter. It doesn't matter. That is the difference between trauma informed therapy and trauma uninformed therapy. That we don't have to be voyeuristic. Tell me everything that happened. Why do I want to know everything that happened? Many times when clients have some shame, something has happened, but I don't want to tell you. I say, I will never ask you. If you want to share, I am okay to hear. I promise I will never ever ask you what happened. I'm not even saying that initially I will not ask you, then you should trust me and then you should tell me. You don't have to ever tell me. And there are people with whom we complete therapy and they've never told me something. Fine. I don't have to be voyeuristic. There was one client who said, I will just give you a code word. I gave him a suggestion that, if you want, you can give me just one keyword or you can give me a code word. Sometimes clients have given me keyword. Green. Okay, what does green mean? I don't have to know. We did the whole therapy with that. Sometimes they say, I don't want to give you even a word from there. I want to give you a code word. You know the difference between keyword and code. Okay, give me a code word. Bottle. What does bottle mean? I don't know. I don't have to know. We can do the whole therapy. So, relying too much on memory, relying too much on what the client says is a very limited way of working with trauma. We don't have to know. Okay? So, as we said, the prefrontal cortex is very highly affected. Amygdala is very highly affected. Amygdala, I told you. Hippocampus will hold the memory much more if amygdala has too much firing happening because of that. If something is making amygdala fire more, hippocampus will remember, I have to hold on to this memory. So, also working memory. What is working memory? Everyone knows. Remembering for a short term like OTP, something, you're seeing one number and you have to write somewhere. So that short term, that also can get affected. Okay, the last point is important. Many times, so that what lay people may say that someone does not want to forget, they want to keep remembering only the negative things. There is something called the positive negative asymmetry or the negativity bias, that the brain remembers more strongly all the negative memories. Like there's a different storehouse in the brain for all the negative memories, which does not mean we should not forget and we should not heal our trauma. But it's understandable that we remember the negative things more. Why? Because it helps us survive. How does it help us survive? We will do the protective mechanism if we can remember the negative things. If we remember only the positive things, we will start flying on cloud 9 and we will not do the protective things. This is okay. I can skip this and leave some time for just one small thing that many times. So, under healthy and normal and non traumatized circumstances, we lead from our left brain, which is logical and linear, not too much focusing on the left brain, but a little more. If someone has had a lot of trauma, then that part gets a little compromised, and the more light is there in PET scans, you will see more lighting up happening in the right brain. After the trauma heals, it moves back to the left and the frontal. Do you know the concept of window of tolerance? Yes? Okay. So, one way of looking at the window of tolerance, everyone knows window of tolerance? No? Okay. So, window of tolerance is the mental space where we feel alert enough and relaxed enough. So, the combination of feeling alert and relaxed is window of optimal arousal or window of tolerance, which is a good place to be in. When we are in the window of tolerance, we are able to achieve a lot of work. We are able to focus on the here and now, on the present, without becoming very hyper aroused. And hyper arousal is when we are more aroused and less relaxed. So, we may have higher heart rate, we have a very high startle reaction, we may have dilated pupils, and we are very hyper attuned to everything that's happening around us. And the opposite is hypo aroused, when we have very little alertness and we are feeling very flop, very lethargic or drained or down and out, and muscles have no energy. People say, no, I can't even lift a finger. So then they are in the dorsal or the hypo aroused zone. So, in terms of trauma informed therapy, there are two broad goals. One is to learn, identify where the person is hyper aroused, or they are here or they are here. But after that, learning skills to come back from hyper arousal or hypo arousal to the window of tolerance. In the moment, right now, I'm feeling here, how to come here. I'm feeling here, how to come here. That is the first goal. The second goal is to gradually widen the window and not make it too narrow, which means that if I feel even a little bit hyper aroused, I should not feel hyper aroused. I should still feel okay because life will happen. Things will keep happening. Or if I'm feeling even a little bit hypo, like here towards the bottom of the window, we can still be okay and feel able to do the work or whatever we are doing. Polyvagal theory I can leave. Okay. So this I have already told you. Now what gives us hope? From neurobiology, what gives us hope is the concept of neuroplasticity. What is the meaning of plasticity? Plasticity means moldability. Moldability, okay? So the brain is moldable. Okay? Some of you go to the gym or yoga or something, some physical activity. I hope everyone does. So when we start doing it, we are not able to do much. Am I right? We feel very tired. Next day also pains. Next day we are walking like this, right? But slowly, if we keep doing it, then we become stronger. Our brain is also like that. Believe me, anything that you're finding difficult, if you keep trying, your brain will adapt to that. In Chinese, there is a concept called gong or qigong, same thing. Gong is that drum, no? So the concept of gong or qigong is that when we do anything for 100 days at a stretch, we will develop new neurons who make it now almost automatic for us to do it. Okay, so neuroplasticity is that wonderful, hopeful thing. So neuroplasticity has a dark side and a bright side. The dark side is that trauma also does changes to the brain. But no problem. No matter what trauma has done, we can still heal it. Believe me, no matter what has happened, it can be healed because of our neuroplasticity. If we are alive, we can still heal. If we are alive, the brain still has the ability to mold things. So, I'll go to the last slide. So, how to be trauma informed, which also means how to be neurobiologically informed. If we just keep talking trauma, and we say we are trauma informed, we are actually not. So we need to be neurobiologically informed. So what does it mean to be neurobiologically informed right now? In the moment, to be attuned to where hypo the person is. In the moment, not this person is hyper, this person, in the moment right now, is this person hyper aroused or in the window? Then we need to be flexible about many different methods, not just different tools, different methods to do assessment as well as treatment. When to do talk therapy, when to do non-talk therapy, when to do assessment using a tool, when to do assessment based on our observation without talking. So different methods of assessment and therapy, that flexibility we need to have because the nervous system is also flexible. And in trauma informed therapy, we do not take the full history in the beginning. Why? We have been taught first take history, then get the diagnosis, then take medicine, then this. Why not history? Due to the risk of re traumatization. Where is the person in the window of tolerance where, and they will go back after the session and then they can't sleep or they are increasing whatever substance or anything because they are trying somehow to regulate themselves. So don't take history in the beginning. History will emerge itself. You start with first regulation, first work with regulating the nervous system. Only after that take the history. Then this, we need to do both top down methods, bottom up methods. Top down methods are all the therapies that we have ever learned: CBT, psychoanalysis, DBT, REBT, everything is top down. They are very nice, very beautiful. Even Rogers, I have also been trained, I still use them, but we need to have flexibility when to use non-talk therapy. So most of the therapy that we do in trauma informed therapy is bottom up. It's at least 80% bottom up, only 20% top down. Then, okay, Gabor Mate, I told you. So physical health, anyone has. You know, when people say, oh, this physical condition, it can never be treated, just take this medicine. You start doing therapy with them, you treat their trauma, you see how. I have clients who used to have I have clients who told me, I did not know what it means to not have migraine. And now for 10 years they have no migraine. 10 years, no migraine. Asthma, same thing I have heard from people. Fibromyalgia, I have not had too much success, but some improvement. IBS, for sure. Autoimmune conditions, for sure. And all these are the ones which doctors will say there is no treatment. But you treat the trauma. And doctors, they're not bad people. I mean, my father's also a doctor, but they don't know about trauma informed therapy. So they won't refer. Then I mentioned a little bit about attachment theory. We don't do trauma informed therapy without an understanding of attachment theory. So your therapy should be a platform for the client to slowly develop what we call earned secure attachment. Anyone who comes for therapy, almost no one has a secure attachment. There are different kinds of attachment styles, you must be knowing. Almost everyone has insecure attachment, but therapy can be a platform for now developing earned secure attachment. If you believe that nothing will change from therapy, I will disagree with you. Even attachment styles change. Then, okay, dissociation, I will not start with now. We will do another workshop sometime on dissociation. So, yeah, the last thing I will just say, there is always, always, always hope because there is neuroplasticity. Okay? And I will leave some time for you for questions or comments, and these are a few book recommendations. Yeah.
Thank you so much, ma'am. That was a great workshop. One comment and one question. One comment is that I completely agree with how we should not fixate on just recalling the memories. That's why trauma informed therapy says that we should rather focus on the effect that the memory has had, and that's how we go forward. One question is that one of the most highest impact of trauma is avoidance or experiential avoidance. So I wanted to understand the neurobiology behind avoidance.
Very good question. Amygdala is your one word answer. Amygdala is firing too much. This thing is cup is there. So, amygdala is firing so much that people are scared that as soon as I even look at that memory, I will become out of control. That's why people avoid. So, you don't ask them to recall, you do overall methods of relaxing the nervous system. Eventually, if they want, when they want, they will tell. If they don't tell, also, you can do a lot of.
Yeah, I think that's dangerous and it's not recommended because you keep repeating it. So I've learned that a little bit.
Yeah, so PET is one of the trauma informed therapies. I don't use it because I believe that without relaxing the nervous system, only prolonged exposure might be a bit, it's very risky. Yeah. What? They use test probes for completing the emotional processing in the trauma informed. Anyone else? Anything? We should close and let you go eat. Yes.
Negative memories. And I just want a clarification that how negative memories and our limit.
Yeah, the amygdala and hippocampus are very close, as I said. So how it helps in coping is that the person thinks I can always remain alert if I keep thinking of the negative things. If you work with any people with anxiety, they are very scared of doing relaxation because they say you will relax me, then I will not be as aware as I should be of this.
Is it the meaning making out of has
It's
anything to do with that?
Of meaning making, it's more of amygdala and hippocampus, their partnership. That's my understanding. Okay, I think we can close. I'm around for lunch and various things. Maybe we can disperse and meet whenever. Thank you very much. I really enjoyed the participation. And I run a very long course on trauma informed therapy. The next batch is about to start on the 9th of January in case anyone wants to join. I think Vibha has attended. I don't know if anyone else has attended. So you are welcome to join. On that group, I will send. You can write to us. PPT, there is nothing in the PPT which is for sharing. Can I just? You can write on this email ID, please.
Thank you, Dr. Anand, for that insightful session. We are now open for questions. Does anyone wants to ask any question from ma'am? Any questions? Okay. Thank you, ma'am, for your valuable insights. I would now like to invite Dr. Deepika Srivastava to please come forward and present facilitation to Dr. Shalini Anand as a token of our appreciation. Please. Come here.
There's an announcement. After the lunch, all of you need to attend the CRE session that will be in the F2 seminar hall. Okay? It's on, there are two sessions. These are theme based sessions on self harm assessment and management. Both sessions are there only in the same hall, F2. Yes.
So what about paper? But what about the other workshop?
Whichever workshop you want to attend, you can attend. Questions will be in a very simple manner. So you need to answer it correctly. Whosoever has the paper presentation, kindly go for the paper presentation. But at the end of the day, kindly fill all the Google forms. Questions are in a very simple manner. Yes, yes.
This was CRE. Just an announcement. Which one? Is there anyone from Vibha named Vibha? Vibha. Who is Vibha? Hello. Please make sure that you have signed the attendance sheet. Just check once, it's here. Thank you. I don't know. हाँ इनकी नाम के लिए लिखा है
एकच पेन आहे काय पेन आहे का पेन ये मेरा नहीं है अभी का नाम ऑलराइट दीपिका मैम ये दो दो क्या है वर्कशॉप वन और वर्कशॉप दो है वर्कशॉप के दो है नहीं इसके दो शीट करने हैं आप किसी एक में भी कर दीजिए इसमें वैलिड किसी एक में भी टाइम दोनों में करना है तो ये मैं फर्स्ट में ही को करना है ना और तुम उन्हें बोल
Okay, great. Thank you. We are sorted now. So we'll get going. So the topic of today's symposium is delving into the therapist's inner world. In our work, we are constantly dealing with our clients' inner worlds, and we are carrying a lot of their inner worlds as well. So I know a couple of sessions here are about the therapist's inner world. In my work, because I'm a trained trauma therapist, so I partake a lot of research which uses trauma framework, one of which is the paths work framework. You may have come across such words as inner child, paths work, internal family systems. So while today's symposium does not have the scope to cover what each of these approaches are, but two researchers that have been done at the School of Human Ecology at TIS, we want to share what our findings were and what light does it throw when we use the pathwork approach on therapists. So let me begin without much ado. The concept of self as a unitary entity has been there forever. And that is how we imagine ourselves as well. We imagine that we would be this consistent set of qualities, characteristics, this one personality which would show up in all situations. So, what is different here is that this concept of multiplicity of personality or having different sub personalities is not something new. It has been around for more than 100 years. And while we know that Freud's theory talks about the tripartite ego and different, different levels of consciousness, before Freud, Pierre Jennings, also considered to be the father of dissociation, talks about different streams of consciousness. And in Freud's theory as well, we look at the personality as having different segments, one unconscious, preconscious, conscious, etc. So when we are talking about this concept of multiplicity of personality, our understanding of these ideas have led us to imagine that personality is supposed to be this one unitary entity, but it's not. It is supposed to be multiple. We are supposed to have multiple sub-personalities inside us. You'll relate to this if you think of different voices that you hear within, different dialogues that go on, especially when you are working with a client. There are different parts of you, so to say. So some of these approaches that have also been around for many decades now is also the framework which was given by Hilgard, one of the most important figures in the field of hypnosis, and Watkins, who are the proponents of ego state theory and therapy. Now, all of these confusing words, ego state and parts of personality, sub-personalities, they refer to the same concept that there are multiple selves or multiple sub-personalities instead of having this one personality. The most recent framework that you may have heard about is this very, very popular framework that has come up since the 1990s, which is called the internal family systems therapy. Internal family systems was propounded by Dr. Richard Schwartz, who is a family therapist in the US. And while he was working as a family therapist, he came up with these ideas that just like the external system, we also have these sub-personalities linked with one another as an internal family. So this particular framework, internal family systems or IFS, as it has been popularly come to be known, has become very popular throughout the world now and has been used for treating trauma and dissociation. Now, this is the most recent framework, and in our research, we make use of this framework to understand therapists' inner experiences. In most of these pathwork approaches, there are two controversies. One controversy is that these sub-personalities or these parts, do they need to be integrated back together, like different slices of a pie or a cake that you want to put together? Is that important? Or do we just let different parts be the way they are, where they feel like they are a happy family together? If you watch the films Inside Out 1 and 2, you'll get an idea about what I'm talking about. So the controversy is around that. Do we have to put Humpty Dumpty back together again? Or can we coexist with our parts having a very harmonious relationship, like an internal family? So this idea of integration and differentiation is what really distinguishes these different approaches to pathwork. Now, this concept of pathwork is also something that the dialogical model, which we often use in supervision for therapists, comes up, which talks about an inner dialogue. We have these different inner thoughts or voices that go on. So we can think of these as different parts of us, parts of the therapist. Each part might have their own,
that was supposed to take place after the symposium is now taking place at the F3 MDP hall. So whoever F3 MDP hall, the hall right across this hall in front of you. The scientific session is starting there.
Okay, all right. So, these different paths have different thoughts, different perspectives, different voices, different affective states as well. So, they may seem like different personalities altogether, having different kinds of concerns. So, this dialogical self model of therapists was given by this group of researchers led by Robert, and they talk about this primary difference between the professional self of the therapist and the experiencing self. So, if you are aware of William James's theory, there is this experiencing I, and there's the I as the the witness. So, the witnessing self and the experiencing self is what James's theory talks about. But the dialogical model says that all therapists have a professional self and a self that is experiencing all the emotions, is also relating with the client. So, in this context, we want to talk about two research that were done. Two of these were master's dissertations that were done by Brinda and Bhavya. The first research that Brinda is going to talk about delved into it. This was a phenomenological inquiry into the inner experiences of therapists who work with clients who are at risk of suicide. Of course, this is very hard work and very triggering work as well. So, Brinda will walk you through the findings and how we got to see different parts of the therapist come up in the work. And then we have Bhavya, who is unable to join us today in person, but she will be presenting online, and she will talk about her research, which delves into the inner dialogue of therapists who are working with complex trauma. Both of these studies, like I said, are qualitative phenomenological studies which inquire into parts of the therapist. So I'm going to hand it over to Brinda, and she will walk us through her research.
Hi. So, you cannot wipe the tears off another's face without getting your own hands wet. This proverb beautifully captures the essence of therapeutic work with clients at risk of suicide and the essence of my research. Therapists are often at the front lines of suicide prevention, serving as primary responders in identifying and assisting individuals at risk. There is agreement in literature that working psychotherapeutically with clients at risk is stressful, anxiety provoking, and causes great emotional strain and personal distress. When working with clients at risk, therapists report experiencing a wide range of emotional responses, including but not limited to anxiety, worry, feelings of helplessness, powerlessness, defeat, and sadness. They express doubts regarding the efficacy of their practice, question their skills and competence, and their capacity to ensure safe and appropriate treatment. Shari, Damadi, and Madden describe this work as one of the most challenging and frightening problems that therapists and counselors can encounter in the course of their work. Research also indicates that individuals at risk of suicide rely significantly on projective identification, unconsciously striving to transfer their own emotions and experiences to another individual. As a result, they are capable of evoking profound emotional responses within their therapists, who often become an absorbing vessel for the complex emotions that are the part of patients' internal experience. Now, I'm going to quickly run us through the key concepts which are central to understanding this research. For the purpose of this study, people at risk exist on a spectrum that runs from non-suicidal self-injury to lethal suicide attempt. Therapist is someone who has received professional education and training, at least at a postgraduate level, in providing psychological treatment to clients. And inner experiences can be understood as all aspects of person's internal processing or explicit memory that allow them to be communicated to others and reflected upon themselves, and certain aspects of their implicit memory which allow us to look for any traces of trauma. Now, despite the evident difficulties and anxiety provoking nature of the work with suicidal clients, as Reeves has commented, there has been little research conducted into the experience of therapists. He proposed that this could be a consequence of the medicalization of suicide. In a culture that relies on risk assessment tools to measure human distress, the process of the assessor understandably becomes a redundant area for exploration or consideration. Although research focuses on therapist experiences of losing a client to suicide, the lack of focus on the experience of therapists working with clients at risk is notable. Additionally, Few researchers have previously attempted to study the inner experiences of therapists, more so in this particular context of working with at-risk clients. Furthermore, the researchers that have focused on it have only touched on the cognitive facets of their experiences or affective states of therapists limited to anxiety and negative affect. They've not classified it or studied it further. There's also a largely overlooked aspect of the insidious somatic aspect of therapist inner experiences. The aspects of therapist experiences that are stored below conscious awareness in implicit memory and the dissociated aspects of experiences that can plausibly serve as traces of traumatic experiences. Therefore, the contribution of the present study in exploring affective states of therapists beyond anxiety is a pivotal contribution to the literature on inner experiences of therapists. Within the gamut of therapist experiences, the study explored the palpable behavioral aspects of therapist experiences, therapist inner experiences, both implicit and explicit, somatic, affective, and cognitive dimensions, and the therapist's interpretations of their own experience. Using a qualitative pedagogical approach with a trauma-informed lens, the research inquired into the therapist's experiences through semi-structured in-depth interviews. 9 therapists from India were interviewed online with experiences ranging from working in private practice, schools, universities, university clinics, employee assistance programs, and general hospitals. The participants were in the age range of 26 to 47 at the time of the interviews. All at least had a minimum of master's degree in psychology. Now, the data which was thematically analyzed revealed a complex landscape of somatic, affective, and cognitive experiences, both explicit and implicit, that shape therapeutic work for this vulnerable population. The first theme talks about the difficulties that therapists report experiencing while working with people at risk of suicide. First and foremost, they report experiencing overwhelming stress, exhaustion, and an overall sense of being overburdened. As one of the therapists said, and I quote, it would be very, very overwhelming, exceptionally hard because a person's gotten to this point because some emotion is too overwhelming. And if that emotion gets deposited in you, you will be overwhelmed too. The second theme that emerges is therapy as hard work. This theme underscores not just the training and educational competencies required, but also the emotional fortitude needed to do this work. Narratives of responsibility and accountability thread through these stories, as therapists describe it as a risky job with very high stakes that they feel responsible and accountable for. Blurred boundaries. This pressure sits alongside blurred boundaries with crisis calls at 2 a.m., holidays turned into crisis management, and the lurking feeling that creeps on you that because it's alive, I can't say no. One of the therapists recalled how once during Gandhi Jayanti leave, while her husband was visiting her, around 9:30 p.m. in the night, she received a message from a client in crisis, and she ended up managing the crisis for about 5 to 6 hours straight. She spent her holiday on it and couldn't spend time with her husband, and it impacted her personal life. The Soma also speaks to the impact of this work, which shows up as high levels of cortisol, disturbed sleep patterns, loss of appetite, insomnia, hormonal imbalances, and overall reduced functionality. The ethical center, recognizing our limits. One of the therapists captured the essence of it when she said, therapists are also human beings with limited nervous system and limited capacity. You can't save anyone who does not want to save themselves. Multiple participants emphasize the need to keep one's own rescuer fantasies in check. Now, this particular section talks about memories that are stayed on, both explicitly and implicitly. This is where the core of the traumagenic aspect of the work sits. I differentiate 2 layers because participants did. Now, the traces of trauma show up in implicit memory, and the narratives of trauma are discussed in the explicit memory later. The concept of traces of trauma memory refers to the fragmented and often non-verbal memories that persist after a traumatic event stored implicitly within the mind. According to Van der Kolk, these traces manifest through sensory experiences such as tactile sensations, smells, sights, sounds, or even specific emotions that are involuntarily recalled without a conscious narrative of the traumatic event. For instance, once during the course of the interview, as a therapist was talking about her work with a patient who'd once walked into her clinic wrapped up in bandages because she'd just come from the hospital as she's very recently self injured. She said that I have to emphasize how overjarring that smell was, that I can still smell it in this moment. She was referring to the stench of betadine solution that was applied on the patient's wounds under her bandages. Similarly, certain another participant during the course of the interview recalled that as I'm sharing this, I suddenly remember the smile one of my friends gave me before telling that he was suicidal for a month. That image flashes before me. And when we touch these memories, the Soma spoke for a participant who said, I have tears in my eyes. Maybe if it was a video call, you would have seen that. So I don't know if there is a change in my voice that you could hear. How far it is visibly heard, I don't know. These are the echoes that linger outside narrative coherence. Now, declarative memory. At the explicit layer, the narratives that could be recalled, participants remembered first and foremost the oddities. Now, these were unusual cases with extremely disturbing case particulars. Secondly, they recalled the spectrum of emotions that the clients presented with, which ranged from shame, despair, anger, and fear to calm, joy, and even pride, as they talked about self injury and suicide. The third thing they recalled were the means, the explicit methods used by clients in suicide attempts or self harm, such as insecticide poisoning, hanging, overdosing, burning. Now, this aspect of their memory talks about the somatic, affective, and cognitive reactions as recalled by them. The somatic reactions experienced by therapists range from tension, rapid heartbeats, restlessness, fidgeting, and sweating to loss of speech, loss of appetite, breathlessness, and a freeze response. These responses speak to sympathetic and dorsal vagal activation in their bodies. These embodied experiences shed light on how deeply they're affected by the pain and despair of those they seek to help. Therapists recall feeling a broad spectrum of emotions, including fear, dread, helplessness, hopelessness, frustration, anxiety, resentment, guilt, sadness, pain, worry, grief, and occasionally also hope and joy. Cognitive reactions. This theme captures therapists' reflections on their inner dialogue, activated schemas, and mental processes when working with clients at risk of suicide. They report a range of cognitive reactions, including racing thoughts, engaging in comparative analysis, drawing on past experiences for guidance, confusion, blanking out, and having an inner dialogue marked by fear of failure and negative bias towards self. Beyond the cognitive experiences explicitly recalled by therapists, our analysis revealed another significant dimension of their inner landscape. Throughout their work with at-risk clients, therapists experienced distinct internal dialogue between different parts of themselves, each part holding different perspectives, emotions, and protective functions. Below, we present the five most prevalent patterns of internal dialogue that emerge from our data. Therapists would often have an anxiously a part that we call anxious achiever, which would sound something like, "What if I fail this client? What if I say something wrong and push them over the edge? I could be responsible for their death." And this is another part that would be in conversation with what we call rational reassurer. This is a little bit more realistic in nature and rational in nature, which would talk about how I have training, supervision, and protocols. I've handled this before. Everything does not hinge on this single conversation. Similarly, therapists would have a part which would feel the intense need to rescue their patients out of it. I must save them. I can't let them down. I must always be available. But at the same time, at the same time, there will also be a part which recognizes their limits and boundaries and understands that I can't control their choices. I have limits. I cannot rescue them out of this. At times, at times a part would show up which would feel rather resentful. Why are they putting this on me? Why do I have to deal with this? This is too much to ask for. But there's gonna be another part which would hold a lot of compassion and empathy for their clients, which understands that they're in immense pain. They trust me with this, and this vulnerability is why I do this work. There's also another part. They also had an overworked functioning professional part often, uh, wherein they felt like they must respond to crisis calls even on holidays. They felt like they're a therapist first and their client's life is at stake, so that must take precedence over everything else in their life. But at the same time, there's going to be another part which feels guilty, which feels like their family needs them too. I deserve rest, and feel guilty for not being present here. Similarly, there's going to be a part which is tuned into their own emotional experience of doing this work, which would feel overwhelmed, which would recognize that their body is tensing up, that they need to breathe and ground themselves. But there might also be another part which does not know where they end and the client begins, which doesn't understand, which all it can feel is their pain and hopelessness. Burnout and secondary traumatic stress, these are the more palpable behavioral aspects of their experiences. The signs of burnout manifested as inability to get out of bed, difficulty paying attention, existential dread, a noticeable change in personal presentation, feelings of hopelessness, pervasive sadness, anxiety, frequent crying, feeling drained and exhausted, and a desire to disappear. The theme Unique Somatic Markers delves into the distinct and often deeply personal physical manifestations of burnout and secondary traumatic stress experienced by certain therapists. These markers illustrate the intense and sometimes alarming ways in which stress and trauma can manifest in the body. A therapist said, for instance, I would feel like my lungs were being filled up with some sort of goo that I just wanted to scrape off. I felt so out of breath most of the time. Secondary traumatic stress does not stop at the clinic door. Family members also bear the aftershock. For instance, another therapist said that it's not always the person who's dealing with the client who alone experiences a secondary trauma. It's also the family members. The night I could not sleep, my husband could not sleep because I kept moving around. I could not sit in a place because I was so restless. Self-care and salutogenic factors, participants emphasize the importance of self-care in creating buffer against the strain, sleep, nutrition boundaries, compassionate detachment, and culturally grounded meanings like karm karta ja or pal ki chinta mat kar emerged as important sources that offer grounding. Nearly all therapists talked about the important role that supervision plays in mitigating the adverse effects of burnout and secondary traumatic stress. Therapists emphasize the essence of effective supervision lies in the quality of the supervisory relationship. Peer supervision emerged as a vital resource when formal supervision faltered. Losing a client to suicide. This was a unique theme that emerged from the interviews with two therapists who had lost a client to suicide. The experience of losing a client to suicide, as described by them, enveloped them in a whirlpool of pain, guilt, loss, grief, fear, anxiety, and a cascade of other intense emotions. Therapists reported feeling devastated and shocked as they grappled with the immediate aftermath. Uh, there are certain other themes which discuss the evolution of the therapist journey when they first started working with active clients and they started working with it after they've been working with them for a while. The wide variety of ways in which both therapists make meaning of self harm and suicide attempts and go about working with it. What came up for clients, what came up for therapists when they were asked to freely associate with people at risk of suicide. I'm going to skip them over because of paucity of time. Talking about sources of satisfaction. Now, this domain of inquiry captures what keeps therapists going given the extremely challenging and demanding nature of work of holding space for people at risk. The intention was to understand their sources of compassion, satisfaction, and motivation. First theme hones in on the raw and intimate nature of the therapeutic relationship. It illuminates how the vulnerability shared within the confines of the therapy room can foster deep connections that almost feel sacred. The therapist also expressed a deep sense of pride and gratification in being able to support individuals in crisis, recognizing these interactions as fundamental to their sense of self and professional identity. For instance, the therapist said, when I support somebody with suicidality and after some time I will see them doing good, in that moment I think that day he was in a situation to end his life, but I helped him to overcome. I feel good. The narratives also underscore the therapeutic profession as a source of continuous learning, intellectual stimulation, and emotional fulfillment, contributing to a rich and rewarding career path that is almost as varied as the individual it serves. Wounded healer, the sense of it was captured by a therapist when she said that most therapists in this field have something they're trying to work on in their lives. The helplessness that you feel when you experience it personally nudges you towards a direction of trying to help other people with it. Positive affective experiences. This theme highlights a deep sense of joy, pride, and gratitude that therapists feel when they see the tangible impact of their work on individuals who struggle with suicidality. One of the therapists called it an above all feeling. Scope for systemic intervention. The theme of multi-tier support underscores the critical understanding of suicide as a complex public health issue that demands a collaborative, multifaceted approach to prevention and intervention. This perspective recognizes the importance of integrating emergency services, healthcare professionals, community volunteers, and a wide array of frontline workers into a cohesive support system capable of reaching individuals at risk of suicide, regardless of their geographical or social location. Therapists advocate for widespread gatekeeper training, mental health first aid, and increased awareness among professional communities to ensure that individuals facing a crisis can access the support they need promptly and effectively. Role bifurcation. The theme of role bifurcation addresses the conflict between institutional policies and the therapeutic model, highlighting the confusion and inefficiency that arises when roles are not clearly defined. So if a person is jumping from the roof, you want the counselors to reach the roof at 3 o'clock in the morning and do what? At what point do you need to call a crisis intervention team and not a counselor? Said one of the therapist participants. Extracurriculars for training and therapists. This team spotlights the critical role that social networks and activities beyond professional training play in shaping a more holistic sense of self among training therapists, whose self worth often becomes very closely tied to their role as therapists. The research illuminates a complex inner world of therapists navigate when working with clients at risk of suicide. Understanding these experiences is crucial for developing trauma-informed support systems for therapists, informing training programs about the emotional realities of suicide prevention work, creating institutional policies that acknowledge therapists' emotional labor, and designing effective supervision models that address both explicit and implicit aspects of therapist experiences. By bringing attention to the often overlooked inner experiences of therapists, particularly the somatic and implicit dimensions, the study contributes to a more comprehensive understanding of the therapeutic process with at-risk clients.
Thank you, Vrinda, for enumerating the findings of your study. We are going to now move on to, so as you saw that apart from the difficult experiences that therapists have shared, we also see the emergence of different voices or parts, as we say. So we'll move on to Bhavya. Bhavya will be sharing her presentation online and will be presenting online. Bhavya, can you hear us? Can we just check if we can hear you as well?
You are audible for me. Can you hear me?
Yes, we can hear you. थोड़ा सा आवाज बढ़ा सकते हैं क्या? You are online presenting. तो उन्होंने ज्वाइन कर लिया है, प्रेजेंट ही कर लिया, थोड़ा आवाज बढ़ा. Go on, Bhavya. I think you can start.
Okay. All right. Thanks a lot for everyone listening. Like Sukanya ma'am also mentioned, as in when I was also listening to Vrinda speak, what was coming up for me that what we are talking about is so relevant overall for anyone who's here who's a therapist also, right? And I'm sure some of us are clinicians and practitioners here. So, when you think of a good therapist, I'd like for you all to take a moment here and just think about what makes a good therapist. Personally, for me, when I was starting my master's dissertation, how it started was I went to Sukanya ma'am and I was like, ma'am, have you thought about how some therapists can have a savior complex of sorts? And then a deep dive began. And it also taught me that, okay, how do I view what a good therapist is? Is she a blank slate? Is she altogether? Is she someone with unlimited empathy, always regulated, unaffected by life's ups and downs? And soon I realized, I stopped describing a person, right? So when you actually think about it, if that is who you are, then how is it possible, right? Because if you look into the literature, it says that motivations for a lot of therapists, and I'm sure some of you here may also connect to this, is because we've seen some kind of wounds of our own, or family distress or something growing up that made us feel like people need more understanding, people need more empathy, the world needs more kindness. And so the journey begins. And as we move ahead as a therapist, we also kind of realize how much the relationship itself has started making a difference in the client's life. And you hear clients talk about that, you are the first person who feels so safe for me, and things like that come up. Of course, we unpack that later, but just bringing this towards the table. So in that way, if the alliance, like you can see here, is accounts for 30% of therapy outcomes, that means that who I am as a person, what I bring to the table, also is a non-specific factor in psychotherapy outcomes. So my personhood, the person I am, apart from my professional identity of a therapist, is very much involved in the space where the client and therapist are existing. So when right now, as we move ahead, we'll be listening to a lot of concepts. Some of you may be familiar with it. Some things you may not be familiar with it. But I think every therapist knows healer and how our capacity that we have been hurt, so I understand the pain of others and how to help them. That is what the core of wounded healer, being a wounded healer, means. But at the same time, how we view it is often different when we talk to different therapists and their style of working and things like that. But the very core part is also that because I have been hurt, I know I can help. That is also what attracts us to this profession. And then, as Brinda and Sukana have already covered, there is an inner dialogue. There is different voices and parts and the self of the therapist that comes up internally while we are in the space. So, for example, if a client is sharing something and you're like, oh my God, am I equipped for this? Especially if this is your first session after your master's, right? But that's the point, that when you're in the space itself, it's not just a conversation between two people, it is also there. For the therapist, it's also within herself. So that is what we're going to refer to as inner dialogue moving forward. Then you may see awareness of parts work. We got a little bit of glimpse what it is. I will also cover it in the next slide a little bit more just to understand the concept as we will be using here. But trauma therapists are mostly trained in modalities that invite the notion that different parts of the self exist and that multiplicity of the identity, as the Kanna was sharing. And in a way, sometimes they get trained to have access to a higher self. So, what does this actually mean? That the self encompasses of the eight C's, or the how Rogers also talk about that congruence aspect of things sometimes, but it is made up of calmness, compassion, connectedness, confidence, creativity, courage, and clarity. While we have these exiled paths, the paths where like we talked about in the start, that we may have seen something in our own family, in our own lives, that have made us feel like, okay, I want to help with this. But if you think about this, what those moments may have brought for us that time is very painful, and those become parts that are isolated from the self. Those are parts that we don't always think about. And in fact, if even there is, until there is a safe space to think about it, we don't really go there. But there may be times, especially if you are working in the profession of trauma, you will hear similar stories where different parts of you, which can be called managers and firefighters, will come up. The firefighter will come up and protect the overall self and exile and everyone in the internal collection, that okay, we cannot go through this right now. Let's not do this right now. This is an emotional emergency right now. We can't do this. And the managers, the story may start creeping up, but it's like, no, right, not right now, but maybe later. And the firefighter, I don't know, and the manager may can it. It's like they also can be posted together as a little bit variation also. But I think it may be more, you may understand it further as we go toward the analysis of it. But based on all of this, we try to understand if paths work is available to therapists, right? And then there we know this brings brought up in the therapy space. So what is actually happening? What are the paths that do come up? And can these paths be mitigated by the higher self, as we were talking about from the
A gentle reminder to the speaker, kindly wrap up the presentation in the next 5 minutes.
Okay. So as I explained this to you, the therapist has some experiences, some childhood experiences growing up, which informs the of the therapist, which then get comes up as awareness in the space, which you then take to the inner dialogue. Now, the inner dialogue is the place for managing your triggers and also managing the personal professional. So we basically explored how do they, become aware of their paths and how the inner dialogue basically plays out. So, and towards it, we also wanted to understand if we can develop an internal family systems and form model of the therapist paths. And so we had 9 trauma therapists. This was a time of COVID, so it was a little tricky to do these interviews, but they all happened from July to November 2021. And these were in-depth interviews transcribed on audio through and it qualitative method of inquiry. It was guided approach, right? As I said earlier, it is also about when we start thinking about these things, and you are a budding therapist, there's many things you think about. It's like I came with a lot of criticism that whoever brings themselves to the therapeutic space is may not be a good therapist and things like that. So there trauma informed ethics involved. Firstly, how can I ground if needed? And confidentiality and informed consent. Consent close-knit community in India. So it was a thematic analysis, as you can see, and there was multi-level of codings. And we had diverse people, but we had therapists who had a minimum of 5 years of experience. So you will see that there are therapists who have more than 10 years of experience as well, who worked in sexual abuse, trauma, relation traumas, and adolescent mental health. So these are the broader things, right? First was understanding the role of the inner dialogue. So inner dialogue in itself becomes a space for reflection and course correction. And then it is also a guide and support system for the trauma therapist. Then there are different parts of the trauma therapist. It's not just the one part which is witness the wound, it's the other parts also, which is unwounded at times also, which is work with each other, which we also briefly saw in what Brinda was talking about. And then since the process is, there are 3 parts to the process, but it can be cyclical at times. I can go towards that right now, and I'll just take a time. These are some really rich conversations that maybe we can share later on for whoever's interested. But how trauma therapists understand this is that there has been a what previously in the literature that, okay, you attend to the client, you process these theories, you focus on your internal experience and manage therapy. But what we've able to do with this study is answer the how. And the how and the missing piece, what we don't talk about often in literature, is the supervisor, who is the third person in the inner dialogue that continuously stabilizes the trauma therapist. So the inner dialogue, like I just shared, is a 3-part process. And what also happens is that this process in itself is also building the relational capacity of the therapist to become more compassionate to herself. So here you see that this is the process that we have found. The trauma therapist feels destabilized by a client's emotions. For example, oh, this is coming up, I'm feeling this is a similar story, this is what happened with me, oh no, something like that can come up. And the inner dialogue may, if they have the resolution, if they can say it's okay, it's fine, we can get through this. If it's not resolved yet for the therapist may do supervision. If it's okay, it goes to the client, of course, right? Because if you're stabilized enough, then the client stories also doesn't feel overwhelming, which means for the client feels, oh, she's not affected by this story as much as others seem to be. Maybe it is okay that this happened to me, only in the sense that it is not the worst thing and this can be manageable. The emotions I'm feeling are much more manageable and can be worked through. So, but in the case that this story or the internal experience still has something more and there's no stabilization being offered, it gets taken to the trauma therapist supervisor who helps create that safe space which the therapist needs and also strengthen the inner dialogue over time so that whatever the supervisor is saying, later the inner dialogue will start saying. And so then the circle just keeps happening and happening as and when new things come up for the therapist. And for older things, when they feel stabilized enough, they are able to work through with the client in the session itself. And they may or they may not take it to supervision, that point of thing. So the other thing about this was to find out what are the multiplicity of identities, right? There are wounded and unwounded parts present, and these are parts that are dynamic and formed by their past. And sometimes they help you to relate with client suffering, facilitate the empathy and counter transference in the session. But having counter transference in the session also means increasing the relationship's capacity to hold more things together, whether it's tougher emotions, experiences, and that means not just for the client but also for the therapist. And the role again of the inner dialogue is so the parts work, right, that we've been talking about. Trauma therapists may know how to do parts work, but it may not click for them that they can use it for themselves. They may not come as compassionately. They may come and a more critical part can come up. And that is where the inner dialogue, as and when it gets strengthened by the supervisor's safety, helps also develop the self of the therapist, which comprises of the 8 C's we initially talk about: compassionate, calm, and all of those things, right? And if you think about from an IFS perspective, therapist then is not a blank slate. We definitely bring our own wounds. We are definitely bringing our own personhood. We are definitely bringing our attachment style that as well, right? So the self of the therapist is there, which enables the presence and reflection, which is the one that is also helping the client feel more held. Then there is the exiled parts, the wounded parts that get evoked by the client story. The firefighter comes in, and in the session itself, with the firefighter, comes in and says, "Why is this coming up now? I'm such a bad therapist." And the manager may come and say, "You know what? We really need to work harder. This is not how we should be going about these things." And again, that self criticism sort of comes in without addressing what the exiled part is exactly wanting to say. So, with the trauma lens, with supervision that is trauma informed, and what is happening there is that the self keeps observing how compassionate, curious the supervisor is to them, and then they also get to unburden. So, then next time in the session, what comes up is, "Oh, this is coming up for me. Let's see where this is coming from. Let's stable it for now, but I need to be stable for the client, but let me take it to supervision. Oh, I'm seeing signs of me overworking. I need to take care of myself." So, in conclusion, what we have understood is that something we knew but is now formalized through research, I would say, that trauma therapists have a lot of these parts. IFS helps to welcome all these parts. The inner dialogue invites that exploration and acceptance of these parts. It stabilizes the therapist, guides her towards self care and supervision, which means that the emotional and relational capacity of the therapist herself is also increasing. And then it also helps delineate, oh, is this the firefighter part coming up? Is this the manager? Is this the exiled part not allowing me to just work in this moment right now? And also have access to the self and notice when the self comes up and goes back or takes a back seat. The implications for this is,
We can wrap up. You can just maybe just conclude with one main implication of the study and we can wrap.
right. So, active supervision and the inner dialogue actually increases, like I just said, relational capacities, which means that supervision itself is very important. And if we think about it in the Indian context, supervision in itself can also include duality of relationships, which we don't talk about enough, which means supervision needs to be accessed for trainees and therapists as a space that helps build a regulating part, which is different from when you have, let's say, a manager wherever you're working, right? So, yeah, that's about it. Of course, there are some limitations to this study as well. But there are future recommendations where we can also invite interviews from the supervisors of trauma therapists. And to conclude, I just like to say that the answer towards who is a therapist is that we are not robots, we are human beings, and to be completely isolating us from an experience, to be dedicated as a therapist or a patient is an experience, and experience certainly changes you.
Thank you, Bhavya. So glimpses of two research work that we have conducted from the lens of parts work in therapists. So I think now we are open for questions, comments, and our chairperson's comments.
Let the audience have their questions. We can entertain one or two queries. Definitely.
Any questions, curiosities that you have about the work or about the research?
Okay, fine. Then I must
Did we have?
thank all the three presenters for giving us a panoramic view of the inner world of therapists who work in trauma. It definitely opens a lot of scope for further extending discussion because a whole lot of things. Therapists who are under supervision, therapists who work without supervision, what stage of supervision, what kind of. The purpose of these kind of inquiry is to be appears that one can understand the risk for therapists who work with possibly in the situation where the vulnerability is very high to get impacted by. So that is common sense. How this common sense is scientifically proven correct or incorrect, that is something we may follow. And such kind of research definitely give us enough boost to go for further inquiries and studies. Thank you so much for your nice presentation. Right? Thank you.
Thank you, sir, for your valuable observations, and I would also like to thank our speakers for their deeply insightful session. As a token of our appreciation, I would like to invite Dr. Tarana Jain, Assistant Professor of Amity Institute of Behavioral Health and Life Sciences, to kindly present the mementos to our dear chairperson and our dear speakers.
Nice. I am
Both can receive for however, I don't have their yes.
Those who are left, kindly come forward and fill in the attendance sheet. About the workshop happening here? Yeah, that is going to begin in the next minute. So, I think
Only exercise I can do. Ask Tejal then. Then we just person for problem मेरा मन में live है. The problem is people are talking about it. Come to follow caskets. नहीं कॉल करो मुझे जल्दी आओ स्टार्टिंग
जूठा तो नहीं होगा वो Empty, please start.
Good afternoon, everyone. It is my great pleasure to welcome you all in the workshop on nurturing minds, building futures, socio-emotional learning, and life skills through school mental health. We are deeply honored to have with us our chairperson, Dr. Manisha Jha, ma'am. She is an associate professor at IBHAR, Institute of Human Behavior and Life Sciences, and her expertise lies in neuropsychology. Ma'am has more than 100 publications on her name. We are privileged to have her guidance and leadership for today's workshop. Um, I'd now like to introduce the other members who are part of workshop. We are honored to have with us Dr. Sudha Janini, Principal of Alok Bharti Public School and Director of Little Story School. With an MA and PhD from Ambedkar University, Dr. Janini has made remarkable contribution in the field of children's education and teacher training. Her unwavering commitment to holistic education has been recognized through the prestigious Delhi Teachers Award. We welcome you here, ma'am. We also extend warm welcome to Dr. Bhavna Bukud ma'am, a RCI licensed clinical psychologist. She holds MA, MPhil and PhD from University of Delhi and currently serves an associate professor at Amity Institute of Behavioral Health and Allied Sciences. Dr. Mukund has served in diverse roles from Indian Air Force and DRDO to Central Tihar Jail and various academic institutions. We are pleasure to have you here, ma'am. We are privileged to have with us Dr. Deepika Srivastava, ma'am, Assistant Professor 3 and registered clinical psychologist and at Amity Institute of Behavioral Health and Allied Sciences. She holds an MPhil from IBHAR Delhi and PhD in psychology from University of Delhi. She has also received the Best Paper Award from AIMS and authored a book on educational psychology. We welcome you here, ma'am. We are delighted to welcome Dr. Nishtha Kumar ma'am, a consultant clinical psychologist, gold medalist and assistant professor at Amity University, Noida. She earned her MPhil in clinical psychology from GMCH and PhD from Brinpas, Ranchi, where she developed a screening tool for learning disability. We welcome you here, ma'am. With such an illustrious group of speakers, today's workshop promised to be a meaningful exploration into how school can foster mental well-being, emotional intelligence, and essential life skills in children. Let us look forward to a day filled with learning, dialogue, and inspiration as we work towards the shared goal of nurturing young minds and building brighter futures. Thank you and welcome all of you again. Ma'am, I request all the to please come on the stage. Ma'am, shall I start now?
Okay. Good evening, all. So, I think we are all pretty late. So, I would request Dr. Nishtha to make her presentation first.
A very warm good evening to all of you. I hope your academic piece is really going well. So today I'm here to talk on exploring idioms and expressions for emotions. So, so when we talk about emotions, what is the first thing that comes to your mind? How we explore our emotions by learning, how to express them creatively, right? So what are the basic emotions that we all can have? Anybody? Disgust, right? So there are variety of range of emotions that all of us as individuals feel every day in our life. So I'll be talking about social emotional learning, need, relevance, and NEP mandate that the government of India had, issued at 2020 for inclusive education. So that to set the tone for the further speakers, my colleagues to talk about the further things. So when I talk about social emotion learning, this has a lot of things to do with theory of mind. Not just to be aware of your own self, that is the understanding, but also able to communicate that effectively with the others, along with collaborating with the others. So what is social emotional learning? That is now becoming a cornerstone of the world in education sector at the present scenario. Why? Because the inclusion of those kids with special needs, which was not seen before, and now has actually come into mandate after the NEP mandate has come in. So that how to provide new opportunities and challenges for creating effective and conducive learning environment. So when we talk about some dimensions of social emotional learning, they are solving problems, wherein the one addresses challenges with emotional intelligence and empathy, adapting to growth, adjusting to changes and developmental stages, expressing emotions, that is communicating emotions clearly and appropriately. This is especially pertaining to the school-going population, the kids, the children, forming relationships with each other. Obviously, this since I talked about collaborating also. So that is building and maintaining healthy interpersonal relationships and connections with the other peers. Also talking about understanding emotions, which is one of the another dimensions, which is recognizing and comprehending persons and yourself and the other person's emotions. So that when I say theory of mind, that is what is not only being aware of yourself, but also being effectively able to see and feel others' emotions and appropriately react to it. So coming down to managing emotion, which is the last dimension of the SEL, that is the regulating and controlling emotional responses effectively. So as a educators, as clinicians, I think this is a joint responsibility for all of us to enforce this in the children from very young age, so that it's better to raise a healthy child than to repair a broken adult. So coming down to competencies of emotional intelligence, as we all know that this is a concept given by Daniel Goleman, and is actually talking about the 5 major things, which is self-awareness, self-regulation, motivation, empathy, and social skills. So these are the 5 key competencies that the Daniel Goleman talked about in his emotional intelligence model. So coming down to the cornerstone for today, which is social emotional learning, the seed castle model is a very important model which I want to just emphasize on. So when I talk about the seed model, that builds upon the castle framework, which is the core cornerstone of the social emotional learning. So when we talk about addressing it to social emotional, cognitive and ethical development of Indian children from ranging 5 years to 10 years. It focuses on unlearning harmful behaviors and relearning adaptive emotional strategies. That is what we actually do in behavior therapy. So, adaptive emotional strategies and reshaping pro-social qualities through, like very early in the age. So, through experiential and reflective learning, that is what the biggest mandate that NEP talks about, which is experiential learning, and not only theoretical or practical, but actually building them, bringing those two things together, so that it's more of experiential learning. That's what CBSE and NCERT is now actually focusing on. Now, this CASI framework, which is developed by the Collaborative for Academic, Social, and Emotional Learning, CASI, is the most widely recognized model for structuring and implementing social and emotional learning in education systems. So what does it provide us? It provides us with a research-based foundation, which is like, not subjective to me or one school or the another school, whereas it's a research-based foundation, which has, integrated emotional and social competencies into certain curricula and classroom management and school culture, wherein me as a counselor, or me as a clinician, me as a doctor would know, okay, what to do and what, framework shall we follow. So my learned colleagues have already developed a seed curriculum. So I think we'll be having the hands-on training with that, on that also in the coming sessions. Now, when I talk about India, sadly, if I talk, there is no training of, teaching of social emotional learning skills to children. It's been only rote memory, which has been focused. Even we have grown like that, the millennials, the 90 kids. So skills to children, and due to scarcity of this SEL, social emotional learning based activities that we were not given in the experiential world. So this is an attempt to make the SEL activities in India using seed book for children to train them and promote them psychologically and physically, emotionally, and build their resilience and problem solving also. So when I talk about 6 core competencies, just to talk about which will be taken later on detail, self-awareness, self-management, social awareness, because social management, once the individual is aware of the self, then only can it, go on to the social aspect. Responsible decision making and this relationships skill development. So this is a structure. I think I'll not waste time on this. We'll be getting the hands-on training this. So this is a session structure in which we have 20 sessions, each lasting for 40 to 45 minutes. 3 to 4 sessions will include family members, etc. Will be told later. And pre and post assessments are obviously good ado to understand that how much, quantitatively if I need to manage something or measure something. So that will be conducted by a clinical psychologist trained in psychological assessments. So coming down to NEP, as I talked about vision and objective, it aims for inclusive and equitable quality education for all learners. Key provisions are ensure support for children with disabilities, gender inclusion, language inclusion, and special education in the sector. Implementation and conclusion would be focuses on teacher training, accessibility, infrastructure, and community participation. Now, how SE is oriented provisions of NEP 2020. So, if we talk about transforming education system, yeah, ma'am, this is so we have reduced examination pressure, one of the core components, holistic pedagogical structure, ethical and moral education, reformed education assessment system, and also multi-dimensional progress reports. So if you see somebody with an LD, since I have majorly worked in my PhD in LD, so what I personally felt was that whenever any child is having a problem, he was, now not ridiculed or looked upon, and actually given a chance to be sent to a counselor and actually, give that profiling of cognitive domain, etc., or be referred to outside clinical psychologist and get the report of this thing done, so that now CBS is also giving provisions, which was not before that. And even when we see RCI Act, it has never, talked about LD was never as a disability in India. But now, if you talk about learning disability, it is actually taken as a disability in India. That is also a really good move in Indian education structure. So this we all know, not wasting much time on this since we are already having lot of time. So these are the key emotional developmental theories we all know: Eric Erikson, Jean Piaget, Daniel Goleman, Vygotsky, Albert Bandura, Erikson social stages. So every child is actually going through, this phases, and that's actually essential for their development too. So what is coming to the last slide? So what is the role of SEL in development of Bharat, new Bharat rather of India? So this promotes mental health and emotional well-being, leading to a more productive population, which we hope and which is a vision of our very dear Prime Minister also. Builds resilience to handle life challenges effectively, enhances academic performances and reduces school dropout rates, which is actually happening now. Fosters empathy, inclusivity, and social harmony in the diverse society. Develops employability skills such as teamwork, communication, and problem solving. Encourages leadership, civic responsibility, and ethical decision making. Reduces stress, conflict, and antisocial behavior. contributing to a safer community, lays the foundation for mentally healthy, emotionally intelligent, and socially responsible generation. This doesn't talk about only the good high IQ scores, but also talks about high EQ scores. Drives, last but not least, drives sustainable national growth and supports Bharat's progress towards becoming a developed nation. So now I'll be handing it over to my learned colleague, Dr. Deepika Srivastava. Thank you so much.
Thank you, Dr. Nishtha. So I hope all of us has gotten the understanding about what social emotional learning is and what are the domains those are associated with this domain. So just to revise the types of emotions, as Dr. Nishtha has already spoken about the types of emotions, we know that there are some primary emotions, secondary emotions, happy emotions, sad emotions, right? So which system of our brain and body regulate it? We all know the limbic system, right? Now, what are the psychological, emotional, and social mechanisms? And what are the domains those are involved in the process of emotional regulation? And how social emotional learning comes into the picture? This is something I will be talking about. So, what is SEL? It is the process of developing the ability to understand and manage emotions, to build positive relationships, and nurture emotionally intelligent individuals who build empathy, adaptability, and equitable community. So, there are four domains which I am going to talk today. One is empathy, another one is adaptability, third one is equity, and fourth one is emotional regulation. Because an individual needs to adapt in their environment in a very positive manner. As we all know, there's so much stressful situation we experience in our day-to-day life. There's so much uncertainty we experience in our day-to-day life. So which factor help us to deal with all these stressful factors, to cope with all the environmental stressful factors effectively? So here FPL comes into the picture. So we know what is empathy, we know adaptability, we know equity, and we also know emotional regulation. So I'm not going to go into the detail of this. Now, how social emotional learning and empathy are related with each other, right? So social emotional learning builds empathy by enhancing emotional literacy. So when I'm talking about the enhancing emotional literacy, this is basically the understanding and knowledge about your emotions and about the emotions of other individual as well. So I know I'm happy, but when I'm interacting with other people, I should also be knowing how other person is experiencing by my conversation, right? So here comes, that is why we say that human is a social animal. So all these things we need to understand. So SCL also promotes perspective taking. It improves communication. It also helps us to deal with the social conflicts. It helps us to reduce prejudice and also increase inclusivity. SEL help us to create emotionally safe environment where understanding and kindness are normalized. So when we are having empathy, we know that we are understanding another individual from their perspective, not from our perspective, right? We keep ourselves into their shoe, which is the mandatory quality of a clinical psychologist, right? So, and there are certain chemical understanding is also there, which is connected with the SEL. So, mirror neurons, they comes into the picture. SEL strengthen prefrontal cortex regulation, hence emotional regulation is balanced. Now, why adaptability is an important part of SEL? Adaptability is basically to understand how to adjust in the environment in a better manner. So when you are not experiencing stress, you are being okay with your environment, you are adjusting with the other people, and you have completely accepted the present situation, hence you are able to manage. So it helps us to respond to the change, it also enhances problem solving, it also brings the resilience into us, and it also facilitates the learning. Now, next is how SEL builds adaptability. So now here we understand why adaptability is important. Now here we are going to talk about the process, the way SEL is building the adaptability. So there are certain other domains which comes into the picture. Number one is self-awareness. Another one is self-management. Third one is relationship skills. Fourth is awareness. And all these four domains help us to take the responsible decision making. So I will be talking about these domains over here in a little bit detail. So all these domains help us to regulate our emotions. Hence, emotional well-being comes here. So what does SEL do? It develops self-awareness. How? By teaching individual to recognize and accurately label their emotions. So I should know how am I feeling. When I'm happy? What are the moments when I'm sad? What are the like when I'm interacting? Who are the individuals who are making me irritated? Who are the individuals who are making me annoying? And what is the reason of feeling of having all those feelings? Why am I being irritated? By just merely the presence of an individual, why am I being irritated? So all these questions one should ask from oneself because this is an important part of knowing yourself. So the moment you are knowing yourself, the moment you are aware about your emotions, obviously you can deal with an individual very effectively. Hence, it strengthens self-management. So when you know yourself better, obviously you will be able to manage yourself better. The third one is it helps us to build social awareness and relationship skills. So we know that when we are communicating to an individual, we are somewhere a part of interpersonal relations, right? We have our parents, we have our friends, we have our boyfriend, girlfriend, we have our colleagues, right? There are so many relationships those come into the picture, and it's a unit, it's a system, and we are a part of system. Hence, many family therapies are being originated nowadays, and many evidence-based managements are coming up. So SEL also promotes reflective thinking. It encourages on our emotional experiences to understand what worked, what did not work, and why does it. SEL also creates supportive environment. So when you know that you are able to manage yourself better, you can deal with the people effectively. And when you know that you are able to deal with the people effectively, the the environment will be in a better way and you will be more adaptable to those situations. Hence, SEL is quite relevant for us to uh, adapt in the presenting environment. Now, this is just a gist, right? This is just a gist of whatever I have spoken today. So, social emotional learning, it manage emotions. How? With the help of self management, number one, and with the help of mindfulness and coping strategies. So, when we are saying that we need to manage we need to manage ourselves, there are some therapeutic strategies, there are some techniques, those help us, right? Social emotional learning help us to express our emotions constructively. How? By making us emotionally intelligent as well as by helping us to adapt more and more negative responses. It also helps us to build up empathy and communication. It also helps us to build up more coping resources and it helps us to bring more self-awareness as well as to recognize emotional triggers. Thank you.
I think we all know emotions and we all are much aware. That's why we all are here. In education, from last 25 years, I have seen that no doubt that in education we led the incredible technological progress. But we fail somewhere if we are not creating the world, the humans with mindfulness, with peace and happiness. So what we need to change in education, in schools, is to involve the SEL
in school education system. So this I have learned and it's my experience. I'm just sharing one anecdote that 12 years ago, 13-year child, she was raped. And after 7 months, she disclosed in the family about it. Because maybe she observed the bodily changes, then she uttered everything in front of the parent. Then the parents came in our school and we realized that why she didn't disclose this earlier. So this is about the fear and emotion I'm talking about. So what our children have to learn that do not hide your emotions. Be expressive. So what's happening or what changes they're feeling. So we just have to train our children first of all that how to be more expressive. We have to give them exposure at school level first. So that's why we have prepared some activities for our children till 10 years so that they'll get more knowledge about the emotions. And these all activities are which the teachers and the counselor can do in the school. So here fear, I just want to elaborate here that fear is a core critical emotion which I have been observed in our school. The children, they have again, and if you deep dive into the emotions, then you realize there are n number of emotions come up of fear. Fear of stage, they could not express, or the fear of exams, the fear to interact with the teachers, and many more. So for that, we researched a lot and we created a model that is the face the fear. So we have to train our children. In fact, you can also do in your school or with your own children that how to face the fear. This is a design model which we have created where the F means find the fact. So here, in find the fact, we just have to label emotion. Children must know that this is fear. They must have to understand by which they triggered and when it hurts. The automatic response, all the signals, the butterflies in the stomach. So this we train them and now they better understand it. So this is again a request to all that we just have to make aware your children and the bodily behaviors like the appetite, how they feel about their digestive system. So this is about the find the fact. Then the second is which is analyze and act. It is a great step forward. Go in details of pros and cons of the fear. That is, when you dive deeper, then you come across how to analyze in this whether that fear is reasonable, that threat real, or it is assumptions. Or am I making imaginations? What is the worst case scenario of the fear? Like when you fail, then analyze that it's not truly the end. We just have to learn and perform the next time. Then the coping with courage. In coping with courage, we just have to teach them with the strategies how to perform, how to make the strategy to cope with courage. That is with deep diaphragmatic breathing, exercise in the potent stress reliever, even a short 10 minutes walk or little exercises. Then to start with the small steps. An exposure therapy, again a strategy for our children, which we just tell them and motivate them to come, take little steps and say 1 line, 2 lines, 10 lines, and they do it effectively. But it is very impactful, I can say. Then the cognitive therapy, Then it's E, which is engage and exhibit. That is again a powerful therapeutic approach. Do engagements with every step and perform fully, rather repressing and distracting from it. So, these are all the points which we have to keep in mind while handling fear in our lives. So now I just have to say that the cost of fear is to live unlived. So treat fear not as a stopping sign, but as a compass pointing towards you to the greatest potential. Thank you.
Evening, everyone. And as we are running very short of time, my topic given to me was social awareness and social management. Now, coming to hands on training, when we talk about training of social emotional learning in school and the prioritizing of school mental health, what is important is what what we will do actually to make the child understand that you have to build understanding of the key component of social emotional learning, that is self awareness, self management, social awareness, and social management. And social management has two components: decision making skills and relationship skills. Building decision making and relationship skills. Now that we talk about, we have understood the importance of these four components, and the NEP, the government states that we should have inbuilt sessions. Now we should start from the very childhood, make the child learn and make them aware of their own emotion and make them socially, emotionally strengthen them so that they can face challenges coming in the later adulthood. How? How will you do that? So, it is our effort that we have established a curriculum called SEED, Social Empowerment Educational Discovery, for taking inspiration from cases SEL. And we have included a lot of activities for strengthening social emotional learning in children. One of the activities, because we are running very short of time, so I'll be just talking in brief. Suppose we have to make the child aware of social awareness. We have to create some kind of social awareness in the child. How you will do? So this is one of the activity we have built up. A buddy or a bully. I'm just giving example in a hands-on training because in a training session you feel like what to do actually. You know it's important. You know that NFP mandate has come. It's important, but how you will do that? So, for example, this is one of a session wherein different situations are given to the child, which you can actually go to us who are school counselors or therapists, or you're finding you come across a child, so there are certain situations given. For example, I'll just read one of the situation. One fine morning, you are asked by parents to get ready for your school. Today is your inter-house match competition. You are a super player of your team, but today you are not getting ready to go to school, and you look tensed. And when parents asked the reason for not going school, you started crying. So this is one situation you have come across. Your child wants to play and he's a good player, but now he's not going for the inter-house competition. Now, how you're making the child socially aware? He started crying, and there are few comments in the remarks. In the sense, when the child tells the parent, through the story that there are my friends who comments to me like this. One of the friend A said, he yelled, "If you come tomorrow, then I will not spare you." Like for the competition. Friend B said, "You look tense. Try to play smartly to win the game." Friend C said, "Tighten your belts for tomorrow's game. We will see you." Friend D said, "You are held tightly by your collar and are threatened and do not dare to come tomorrow." One of your friends said this. And friend E said, "Many a time your it's a situation again that many of time your bad ball cricket bats have been stolen or broken repeatedly and intentionally to let you not able to practice regularly." So these are the different types of remarks, comments, situations that a child might face. How you are making the child aware that he is socially bullied, he's bullied, or he's just being friends with those group of friends, classmates, because you are hanging out with them. So these are the methods. Their activities are the methods which will enable you, the child, to understand that the people they are residing with, the people they are living with, the classmates, the friends, in that particular situation, are you socially aware that they are a true friend, or are they a buddy or a bully? Are they a bully? Because bullying is a very serious issue in when it comes to schools and colleges, right? Likewise, there are different types of situations we have created. Like you have gained a lot of weight and you are heaviest child of your class. This is one of the situations. And there are remarks coming to you. So through the remarks, the parents can always, when the counselors, the school counselor will help you to do these activities, they will get an answer to it. And when they get an answer to it, they will try to understand, the school council will try to understand and you yourself will develop an insight if these remarks are positive, if they are constructive, if they are making you happier, if they are making you feel better, make you feel relaxed. And if not, if they are destructive, if they are giving you tension, you're not feeling well, you're not able to perform. So you are able to understand the friends that you're hanging out with, the people, the group of peers that you are living with, are they really your true friends? Or in a way, just because you want to be with them, you want to be in the situation, you want to have friends, don't want to be socially isolated, but then you don't recognize them, that they are not your true friends. They're actually buddy or a bully, or they're actually a bully. And when you once the social realizations come to you that yes, I'm actually being bullied, this is not right, this is not what should happen to me, this kind of friendship is giving me more tension than being more happy and relaxed. There is a certain level of social awareness is generated, and then you can actually learn to take some steps towards it. Maybe you inform your parents, maybe you would want to inform your counselor, to your teachers, to understand that this buddy or bully or this kind of social awareness will help you to stop that kind of negative consequences. This is one of the activities that we have a lot of curriculum, a lot of 100 activities. This is not now, we don't have the time for that in the book. If you see that we have plans, these are the different ways through which you can actually help the child to understand and build social awareness to different kind of activities for social emotional learning. Similarly, there is another activity I would like to talk about. Just two activities I'll talk on. The name of the activity is My Train Track. Now, suppose we are just helping the child, a 10-year-old child, to imagine that you are the main officer in charge, taking all your brothers, sisters, and cousins to a happy journey with a motive to strengthen your emotional bonds with each other. Suppose we give a situation in the class like that. That all the children have to imagine this, and you started your journey from a normal junction, just a station, and you have to drive your train to a happy junction. This is your journey. And see, you can relate it like that, that life is also a kind of a journey. Right. In your life journey, you will going to meet lot of emotions. Some happy, sad, disgust, anger, fear, lot many emotions. Which emotions are you supposed to keep, and which emotions are you supposed not to keep? How will you know that? How a child will know that? See this, because I'm taking a session on, like, my audience is adult, but just imagine 10-year-old child, 10-year-old child to understand that I have to manage my own emotion. I have to do socially manage all my relationship, because this is a train and I'm the train driver. I'm the officer in charge. This is my life journey, and in my train journey, who are my people carrying me? Sisters, brothers, cousins, all of my relationship. Now, when I am taking the train from a normal junction to the happy junction, I am मुझे पहुंचना है. Now, what should be my ideology? What should be my take? How am I supposed to build and strengthen my social and emotional positive side of it? How should I strengthen my social and emotional side of it? So we have planned an activity that your train is passing to different junctions. And the name of the junctions are sharing, food and cooking junction, complaining station, then laugh, joke and smile station, celebrating success stations. You have a lot many comparing junction, advices junction, caring and loving station, party together station, ignoring station. Then we have teasing station. We have wishes junctions, birthday station, and welcome and hug junction. So if you see the junctions that are coming in between are also negative, like fighting junction, jealousy junction, okay? Respecting different junctions, expressing ideas. Now we have to tell the child, it is your prerogative. Think deeply, analyze, feel, and think of the relationship and think you are the officer in charge of the train and your train will pass through these junctions. How much time would you like to spend on these junctions, like jealousy junction? And if at all, it's a life journey. You have to reach to the happy junction. You're starting from the normal junction. In between, these junctions will come. Jealousy junction will come. What you will do? Will you halt your train there and then? And how would you deal? Because junction will come, stations will come. When you go to a journey, a lot many stations come. So there will be a station, something like jealousy junction, something like fighting junction. So there will be some fight. What will be your priority? What would you want to manage? If at all my train stops at a fighting junction, so a child might give an answer that I will not halt my station for a long time. I will not let my train stay there for a longer time. I will try to resolve what is causing the fight. I will try not to have jealousy. I'll try to resolve something. And likewise, when it comes to different good stations, like expressing ideas, when it is something like, wishing New Year festival stations, welcome and hug junction, I would like to make my train stay more. So, in a playful way, they will learn to maintain social relationships. They will learn to maintain that there will be times in our life and different kind of difficult situations will come when I am traveling with my own cousins, my own family members, my own siblings, my friends and relationships. Now it is my duty to understand how will I am supposed to manage and where would want to halt for a how much longer time duration and why, and if not then why. So these are the activities. We have just taken some activities where we want to, through the activities, we want child to at least learn to initiate that level of thinking. At least think on those lines where they learn from the very beginning that it is their duty, it is their way of living. In fact, it's a social emotional learning is a way of living. How am I supposed to live in a way that I am not causing much kind of destruction to my own self and to others? And how am I preserving, nurturing my own relationship? How am I taking the right decision? And what could be the other ways? One way is lecture. We can do some lecturing to them. We can tell them what is right and wrong. Second, we can ask them to have an experience of that. It will take time. Third, we can have activities like that where they are initiated to actually think on those lines. What could be my decision, and leading to more of self management, social management. You are trying to manage your social life. Similarly, there were another activities like called as just impact. Suppose the impact, we have created an acronym of impact for planning. Suppose we have to make the child learn any activity, just clean your almirah today. This is your task. How would you do? What steps? Clean. If we just give an instruction to a child, no, you're supposed to clean your almirah today. No, no, you have to do the homework today. You have to prepare for the exam. Then it's kind of a pressure or burden. But if we say, do you learn steps? Do you have ever thought what would be the basic ways from which you can actually, have an idea of doing things and learn the mastery of planning so that you are always planned and emotionally strengthened. You know the ways to overcome a problem in a situation. Yes, ma'am said about fear. So if I asked about planning, so I can teach them that should be an idea. If you have to do anything, if you even have to clean an almirah, you need to have an idea how to do that. You should have a good amount of motivation. You should know the process. What is the process, right? And knowing the process, you have to attempt to act, and then you have to check back the progress of what till now, where have you reached, and then target within the time frame. Any act cannot be done without it always has a time limitation. तो एग्जाम का भी एक टाइम लिमिटेशन होती है, हर छुट्टी की भी एक टाइम लिमिटेशन है, दिवाली की भी छुट्टी आई तो विद इन द टाइम फ्रेम. So you have to, if you learn to do your task like this, that you learn to know that I have an idea for my task? Am I adequately motivated? Do I know the process? How am I supposed to do that? And am I doing it rightly? And how am I saying check the progress? Because you have to know that till whatever you have attempted, is it right in the right fashion? And if it is done within the time frame, kudos, you are successful. So you have lower down your own stress. You are more emotionally balanced. You know planning. You know decision making. So you are becoming what? Ultimately, the goal is to become what? More socially aware, more self-aware. You are able to manage self. So when you tend to learn exercises like that and techniques like that, you internally build strategies for social
Sorry
emotional
to
learning.
interrupt, Dr. Bhavna, if you could wrap up.
Yeah. So these are the activities through which you can actually make yourself and child learn social emotional learning. Thank you. Any questions? No.
Thank you so much, all the speakers. We are already running late, so maybe we can take quick one question if anyone have. No? Okay. So quickly, I would like to just give a few comments. So I think Dr. Nistha has set the tune rightly with the social emotional learning and initially about definitely awareness of anything is important to initiate any kind of therapeutic work, and it starts or begins with the self. So awareness of one's own emotion is really important, and then since we are into interaction with others, all the communication interpersonal relationship is between two people. So unless we are able to understand others emotion, feelings, intentions, belief, we won't be able to indulge into right kind of interaction. So Dr. Deepika basically talked about awareness of others' emotion. Dr. Sudha was talking about face the fear. I think when we are talking about a child from developmental perspective, so just mere observation is will fill all the gaps. So I think we must have observed a child, even if a small child somehow passes urine in his clothes. So he will always try to hide it. Not because this is one simple example, not because he's ashamed of this, mostly because he's fearful of the consequences. And those consequences are mostly in his head. She was rightly pointed out that दिमाग में ही वो चीज बन जाती है कि लोग क्या सोचेंगे, right? So unless I understand the reason for fear, and so this is the beginning, and we all carry this throughout our life. And Dr. Bhavna and Sudha, I would really like to congratulate both of you for your amazing work. I was just going through these books, and the way you were describing about your module or about your intervention, I think it's both assessment and intervention, right? Yeah. So, and it's especially for young children, till the age of age means 14 10 to 14 years of age. हाँ 8 साल के बच्चे यूजुअली 14 साल के होते हैं आजकल केस में. So we all can understand that young children definitely have limited language capacity, and when they have limited language capacity, so expression is also restricted by their language ability, not necessarily because they are not able to express their emotion. And therefore when you are giving certain prompts, like in prompts as you were explaining about the train scenario or something else, they are more able to express their right feeling, that what kind of people they would like to spend time with, what kind of people they would like to play, they would like to have jealousy with, what sort of emotions. So given that situations and given that prompts, they are better able to express themselves. Similarly, it is also about labeling their emotion and feeling. So just understanding their emotion and feeling is important, but definitely I need to label that feeling to work upon it. So that way, I think your this work is definitely going to be very very relevant and important resource in this field. So I congratulate all the four presenters for their presentation. Thank you so much.
So it was a day filled with learning, dialogue, and inspiration as we worked together towards the shared goal of nurturing young minds and building brighter futures. Now I would request Dr. Tarana Jain to facilitate our chairperson and speaker. Dr. Manisha Jha, ma'am. Dr. Nishtha Kumar, ma'am. Dr. Deepika Srivastava, ma'am. Dr. Sudha, ma'am. And Dr. Bhavna Gokul, ma'am. Thank you so much, everyone.